support in nursing services. First, for all, let's pray and thanks to God, Allah Subhanahu wa Ta'ala, who has been giving us some blessing, happiness, healthy, safety, and the opportunity to take part in this nursing webinar today. First, please, you can read safety induction in the screen. Participant, I expect pay attention, to comfortable ergonomic sitting position during the event. Sit the viewing distance of the computer or mobile screen and adjust the screen display size not too small and not too bright. Follow the 20-20 rule when staring at the computer and cell phone screen. Every 20 minutes, look everywhere 20 feet, about 6 meters, from a sitting position, then stare at the object for 20 seconds. Pay attention to electrical hazard or charge cable or switch around you. Ensure adequate fluid and nutrition intake as well as quiets to participate in the webinar until it's finished. Information for participants who have completed their final absence and leave the meeting. Guideline for attending an international webinar. Make sure you have registered and received the invitation link for the webinar. Check the webinar schedule and make sure you adjust your time correctly. Time zone difference should be noted. Ensure internet connection is stable and fast enough to attend the webinar. Use quality headset or speaker to listen to the audio clearly. Make sure your room is quiet and comfortable so you can focus on the webinar. Don't forget to prepare questions or take notes during the webinar. Do not record or share the webinar recording without permission from the organizer. Do not engage in disruptive behavior such talking off, topping, or engaging in inappropriate behavior. Make sure to say thank you to the webinar organizer after the event. Thank you. Okay, ladies and gentlemen, our event today will certainly provide many lessons for us about pediatric cardiac arrest algorithm, coronary nursing, update cardiac arrest management, and post-cardiac arrest for maternal and neonatal, and update bradycardia and tachycardia nursing management. All speakers in this webinar are experts in the subject. There are Mr. Donald Escano, PhRN, SEED, RN Man from Tarlac State University, Filipina. And second, Dr. Lee Wan Ling from Nursing Program, University of Malaya, Malaysia. And third, Professor Dr. Pratu Maripto from Faculty of Nursing, Naresuan University, Thailand. And the last speaker is Mr. Ii Ismail, Master of Nursing from Harapan Kita Heart Hospital, Jakarta, Indonesia. At this scientific moment, I would like to say welcome to all speakers, Manager of Education and Training Madani Heart Training Center, Dr. Mira Asmira Janti, Master of Nursing, Head of the Nursing Master Program, Faculty of Heart Science and Technology, Jenderal Ahmad Yani University, Dr. Iin Inayah, Master of Nursing, and then Secretary of Cimahi City, Representative Council of the Indonesian National Nurses Association, Mr. Krishna Wisnu, Master of Nursing. And ladies and gentlemen, this webinar was organized by the Madani Heart Training Center and the Nursing Master Program, Faculty of Science and Technology, Jenderal Ahmad Yani University. The agenda for today's webinar is first opening, second, sing a national anthem Indonesia Raya and Mas Indonesia National Nurse Association, and welcome remarks, and finally, main session of the International Nursing Webinar. Ladies and gentlemen, please remain sitting up straight for the Indonesia National Anthem and Mass of the Indonesia National Nurse Association.
Indonesia tanah airku, tanah tumpah darahku. Di sanalah aku berdiri, jadi mandu ibuku. Indonesia kebangsaanku, bangsa dan tanah airku. Marilah kita bersatu, Indonesia bersatu. Hiduplah tanahku, hiduplah negeriku, bangsaku, rakyatku semuanya. Bangunlah jiwanya, bangunlah badannya untuk Indonesia Raya. Persatuan Perawat Nasional Indonesia, wujud ikatan profesi perawatan, tempat membina dan mengembangkan kemampuan diri dalam membuktikan keberadaannya. Menapaklah dengan keyakinan lebih pasti, sejajar dalam abdikan diri, bangkit berdiri dan langkahkan kakimu itu, menatap hari esok penuh asa. Wahai perawat Indonesia, bangkitlah dan majulah untuk menolong sekalian yang menderita. Kuatkanlah pribadimu, tingkatkan pengetahuan untuk memberikan asuhan keperawatan. Kita melangkah untuk mengisi pembangunan bangsa negara Indonesia, untuk mengantarkan bangsa menuju sehat semua dengan semangat jiwa Pancasila. Maju perawat, majulah dalam kancah pembangunan, tunjukkanlah pada sekalian orang. Jadilah perawat model kesehatan bangsa kita, jadilah teladan dalam hidup sehat. Bangkitlah perawat seluruh Indonesia dalam mengemban citra profesi, menjunjung tinggi kode etik keperawatan, laksanakan panggilan tugas mulia, mencapai derajat kesehatan seoptimal mungkin bagi warga negara Indonesia. Sebagai bukti kiprahnya mahkota putih suci dalam mendukung pembangunan kesehatan. Dengan organisasi PPNI yang kokoh, padu bersatu, serta selaras, perawat Indonesia akan mampu angkat hanya di mata insan dunia.
Ladies and gentlemen, now let's continue to the next agenda. Welcoming speech from the Cimahi City Representative Council of the Indonesia National Nurses Association will be conveyed by the Secretary, Mr. Krishna Vishnu Sakti, Master of Nursing. This time for you, Mr. Krishna. Hello, Mr. Krishna. Are you here? Okay, yeah.
Yes. Okay. Thank you, Mrs. Murti, as MC. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Good afternoon and best wishes to all of us. Who I respect, head of the Master of Nursing Faculty of Health Science and Technology, General Ahmad Yani University, Dr. Iin Inayah, SKP MKep, Manager PT Madani, Dr. Mira Asmirajanti, the speaker, Dr. Lee Wan Lim from Malaysia, Donald S. Escano Eran, Magister Art Nursing from Philippines, Prof. Dr. Pratuma Ripodopo from Thailand, and NS Lee Ismail, SKep Nurse MKep SP KF from Indonesia. Praise be extended to presence of Allah Subhanahu wa Ta'ala, who has bestowed His grace, taufiq, and hidayah to all of us. Salawat and greeting may be bestowed upon our Master, the Prophet Muhammad Sallallahu Alaihi Wasallam, along with his family, his friend, and his follower, include us. Hopefully, we will all get his intercession at Yaumaza later. Amin. I really appreciate the nursing seminar organized by PT Madani, collaboration with the Master of Nursing Faculty of Health Science and Technology, General Ahmad Yani University, Ventura Master of Nursing, and PPNI. I hope the international webinar update Advanced Cardiac Life Support in Nursing Service can run smoothly. The webinar material this time is very good for us to apply to in social life, especially our patient wherever we are. Of course, with resource person who are expert in their field who can update our knowledge. Whatever conflict with source who are very experienced in their field. With this seminar, of course, it can be useful as our nurses to upgrade our scientists. Of course, this from of our dedication to our patient where we work, and also increase the professionalism of nurses in carrying on quality nursing service, so that optimal health and well-being are achieved nursing profession. Therefore, I would like to thank all the webinar speaker, the committee of all participants for the time spent generally improve our quality as professional nurses. Lastly, I would like to thank the manager of PT Madani, Mrs. Dr. Mira Asmirajanti, to head of the Fitkes Unjani Nursing Study Program, Dr. Iin Inayah, SKP MKep, because so far he has collaborated with Indonesian National Nurses Association and Faculty of Health Science and Technology, General Ahmad Yani University. Master of Nursing Study Program has established operational since 211, now has 6 specialization: mental nursing, community nursing, maternity nursing, nursing management, pediatric nursing, and medical surgical nursing. Currently enrolling now student from Master of Nursing registered now at registration unjani.ac.id, or you can contact the admin of the webinar committee. Finally, I congratulate you on participant in this webinar. I hope then what we are doing to will receive blessing from Allah Subhanahu wa Ta'ala and will benefit of us and our passion wherever we are. Those words not place. Wabillahi taufiq walhidayah. Wassalamualaikum warahmatullahi wabarakatuh. Good afternoon.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mr. Krishna Vishnu, for welcoming speech from the Indonesia National Nurses Association of Cimahi City, West Java Province, Indonesia. Ladies and gentlemen, for documentation, attention please, open your camera, prepare your best smile. We will take photos. For information, the attendant link will be shared in the chat column after the first speaker has finished delivering the material and answering question. Okay, ladies and gentlemen, entering the main session of the International Nursing webinar will be guided again by Mrs. Musri Kamdah, Master of Nursing, as a moderator. Okay, Mrs. Musri, are you ready?
Okay, I'm
Yeah.
ready.
Okay, yeah. Okay, hopefully in this webinar, Ivan will provide new insight and knowledge again about update advanced cardiovascular life support in nursing services. Relax and enjoy with this webinar. Mrs. Mustri, I invite you to guide this webinar until 5:30 p.m. West Indonesia time. Time is
Okay.
yours. Thank you.
Okay. Thank you, Mrs. Murtiningsih. Good afternoon, all participants. Thank you for finding time and joining today's webinar. My name is Musri Kamdah, and I'm a nursing lecturer at Faculty Technology and Health Sciences, Unjani. Okay. As long you attend this seminar, you face a technical problem, please first check the following basic: your internet connection and computer or headphones properly connected, or volume level appropriate or not. Okay, and notes for webinar. For audience, as has been announced, in the second day on 2nd July 2023, International Nursing Webinar takes the big theme, Update Advanced Cardiovascular Life Support in Nursing Services. Before presenting the subject, let me give a little introduction related to article that will be delivered by presenter. Basically, scientific forum like this are even important and interesting to follow because a lot of information will be obtained. However, it should be noted that the delivery of this information will be easier to understand if the discussion runs effectively. Therefore, it is hoped that all audience will pay attention and participate in the discussion as interactive as possible. Right, then I will convey some of the profession our care event. Repeatedly, the profession of our core event as follow. A speaker has 40 minutes for deliver the subject and 15 minutes for Q&A. As long as the presenter deliver the subject, participants are not allowed to interrupt. The question and answer session will be open after the presenter have delivered their subject. We advise you to type your question in the message box. Thus, a moderator will be able to select interesting questions. Such a system will also make it easier to keep order. Now we begin the seminar. Hello, Mr. Donald. Good afternoon. Are you there? Okay. But
Yes,
your
good afternoon. Can you hear me clearly, ma'am?
okay, but your voice have a problem, not clear.
It's not clear. Yeah, I think so because we have poor internet connection. So actually, I'm trying
Okay, okay,
reconnect on the internet connection because it's a little it's raining.
okay. Okay, the
Can you hear
audience,
me?
please give attention. Mr. Donald Escano will be present about the highlight of the guideline of 2020 American Heart Association Pediatric Cardiac Arrest Algorithm. Please, Mr. Donald Escano, you have 40 minutes for presentation, and I will remind you if the time 5 minutes left. Please deliver your speech,
Okay.
sir.
Can you hear me clearly first?
Yeah.
Because we,
No, it's
yeah,
better.
we have, now it's better.
Yes.
Okay. Because we have poor internet connection here now because it's raining. But I think I have to go out for a while. I have to go out and turn off my video because the internet connection is poor and it's raining here. So I just have to go out for a while. Please give me three
Okay.
minutes.
Okay. Eh, mohon bersabar untuk all audience because Mr. Donald face the problem about the connected of internet. So be patient for a moment.
Yeah. How about now? Can you hear me
Yes, it's clear and better.
better? Okay, good. Because there's power interruption here now, and it's quite raining. That's why the signal is poor. So I have to turn off my video and to share my screen. And today is the continuation of the discussion yesterday. So yesterday we discussed about the adult cardiac arrest algorithm.
Hello, sir. Your PPT is not running. Hello, sir. Your speaker still unmute.
How about now, ma'am?
It's okay now.
Okay, can you please make me a host so that I will not be muted? Can you please make me a host? Okay, so I will repeat this slide. I'm so sorry for the technical problem. Okay, I'll repeat that. Can you hear me now, ma'am?
Oh, yes, it's clear,
Okay,
sir.
okay. According to the United States of America, there are more than 20,000 infants and children each year who have cardiac arrest, because we are just familiar for the adult cardiac arrest. So imagine 20,000 infants each year. And according to the studies, if the cardiac arrest happens inside the hospital, because there are healthcare provider there already, so there is a good survival rate. But when the cardiac arrest happen outside the hospitals, the survival rate remains poor, because there are no team that can cater those cardiac arrests outside the hospital. So maybe there are a problem about the trainings and equipments available outside the hospital. Just like yesterday, there is the same issue from adult. The incidence rate of sudden cardiac death per 100,000 people years was estimated to be 34.4 in Europe, 53.1 in North America, and here in Asia, there are 59% and 49.7 in Australia. Algorithms and visual aids were revised to incorporate the best science and improve the clarity of the BLS and ALS resuscitation providers. So the main purpose why we are having the new update is to incorporate the new or the best science step to improve and to have a more important and more specific guidelines in administering ALS and BLS. Okay? For the purpose of the pediatric, when we say pediatric, our client here is from infant up to 18 years of age. Okay? Excluding the newborns, because there is a different guideline for newborns. Okay? So our client here is only from infant to 18 years old. Above 18 years old, they will be considered an adult client. Infant guidelines apply to infants younger than 1 year of age. Child guidelines apply to children approximately 1 year until puberty. So we have to define this because this is our considered client in pediatric. Okay, for teaching purposes, when we say puberty, there are development in the breasts for female and axillary hair in males. For those with sign of puberty and beyond, meaning to say they will be considered an adult client. So you have to use the algorithm for adult guidelines. So the American Heart Association updated the pediatric BLS support guidelines since the last update in 2010 to 2015. The new recommendation focus on airway management, emphasizing the pediatric patient with advanced airway. We should have a target respiratory rate of 1 breath every 2 to 3 seconds, or equivalent of 20 to 30 breaths per minute. So the changes from the old guidelines, the past recommendation is about 1 breath every 6 seconds only. The past recommendation is about 1 breath every 6 seconds only. But today, 2020 and up, 2020, 21 to 2023, okay, our new recommendation is rate of 1 breath every 2 to 3 seconds. That is equivalent of 20 to 30 breaths per minute. So that is one of the major changes here. The two indication, okay, for the use of BLS, okay, who are the candidate, okay, for us to use the BLS or the new algorithm, okay, guidelines present the two indication in critically ill or injured infants, okay. What are those? Number one, those pediatric who have cardiac arrest with no pulse, and bradycardia, which is heart rate less than 60 beats per minute with poor perfusion. I repeat that. Those clients who have cardiac arrest with no pulse, and those bradycardic with less than 60 minutes beats per minute. So those are the two indications to use BLS. So what are the major issues and changes in 2020 guidelines from the past recommendation? Okay, based on the new available data from pediatric resuscitation, the recommended assisted ventilation rate has been increased to 1 breath every 2 to 3 seconds. I repeat that there is an increase of breath. Okay, one every 2 to 3 seconds, which is was discussed a while ago. That is about 20 to 30 breaths for all pediatric resuscitation. Please take note on that. Okay. Next is the cuff ETT. Okay. For the ETT tube are suggested to reduce air leak and the need for tube exchange for patient of any age who require intubation. Another changes, you know what, the cricoid pressure during intervention. Now for the pediatric patient, we are not using that today. I repeat, the cricoid pressure, okay, the cricoid pressure, we are using that when we are inserting the ET tube, okay, but today, okay, for the new recommendation, that is not recommended anymore for pediatric patient. Okay, that is to maximize the chance of good resuscitation outcome. Okay, another recommendation here to maximize or to increase the good resuscitation outcome. It said that under pediatric, you have to administer the epinephrine, okay, within 5 minutes after the cardiac arrest, especially if it is inside the hospital. According to studies, there are more survival rate to those clients who receive epinephrine within 5 minutes after cardiac arrest. If it is longer than 5 minutes, according to studies, there are more morbidity or death rate. Okay, so that is one of the major guidelines. Again, I repeat, the cricoid pressure upon insertion of ET tube is not recommended anymore, and the epinephrine should be given within 5 minutes after cardiac arrest. That's according to studies, because those patients who receive epinephrine after 5 minutes or within 5 minutes after the cardiac arrest has increased survival rate. Another major changes here for the patient with arterial line in place, using feedback from continuous measurement of arterial blood pressure may improve CPR quality. Another recommendation here is after the return of spontaneous circulation. What is the return of spontaneous circulation? Meaning to say the client may able to cough, the client may able to breathe, the client is hemodynamic stable, meaning to say the blood pressure is getting back to normal or the blood pressure is getting more stabilized. That is the meaning of return of spontaneous circulation. So after returning of spontaneous circulation, the patient should be evaluated for seizure. Okay, the chances of seizure or status epilepticus, okay, and any convulsive seizure should be treated. Again, the difference from the adult, okay, to pediatric patient, to those client after the returning of circulation, you are monitoring for neurologic signs and symptoms here. What are the neurologic signs and symptoms? Which is the seizure, convulsion. Okay, so when the client is having a seizure or convulsion, you have to protect the head of your client, especially these are the pediatric client. Again, what is ROSC? The ROSC is the resumption of sustained perfusing cardiac activity. All right. Again, what are the things that you have to monitor after the ROSC? Neurologic signs and symptoms. What are the neurologic signs and symptoms that you are watching out? The seizures and the convulsion. Another changes here, because recovery from cardiac arrest continues long after the initial hospitalization, patients should have formal assessment for support for their physical and cognitive psychosocial needs. So you have to assess the cognitive function of your client after cardiac arrest, and also the psychosocial needs or the support system of the pediatric client or the family, because we have to care for the pediatric client holistically, not only physical aspect. Next is a titrated approach to the fluid management with epinephrine, okay, or norepinephrine infusion if vasopressors are needed, and it's appropriate in resuscitation from septic shock. Okay, so
My
there are,
apologize, sir. My apologize.
yes,
Your PPT is not running.
It's not running again. Okay,
Yes.
how about this one?
No,
How about this one?
I cannot.
Oh, what's the problem? Okay,
Yes.
I will stop sharing and do it again.
Yes.
Okay, I was going to share my screen for a while. This is one of the challenge in online webinar. Okay, I have to share it again, but when I am sharing it, my microphone is getting mute. So please make me the presenter so that my microphone will not be mute. Okay, I'll share my screen again.
Okay, please, sir.
Okay, what is happening here? When I am sharing my screen, my microphone is getting muted. So can you please make me a host? I am a host here. Can you please make me a host, ma'am? Because when I'm sharing my screen, my microphone is automatically getting mute. I don't know what is the
Okay.
problem. So I'll try it
But
again, okay?
okay, we could help you, sir, but you have to share to us your PPT.
Hmm.
The administration will help you to share the PPT.
Okay, for a while. I don't know what's the problem, but yesterday we have a good presentation. I don't know what is happening today. So Dr. In, I'm going to send. I believe I sent my presentation to Dr. In already.
Okay.
Okay, okay.
Can you get it
Yes, yes.
to Miss In? Okay, but
Okay, yes.
uh, I think you can still listen while we are waiting for the PPT. Okay, I'll continue to discuss slowly. Okay, Can you still hear me?
Yes, we are still
Okay,
stay with you.
okay, all right. So another changes here is the norepinephrine. Where did I stop? Where did you didn't hear me? Did I discuss the ano? Did I discuss the cricoid pressure and the epinephrine? Did I discuss that? Can I ask a question? Okay, the epinephrine should be given within how many minutes? If you're listening to me, how many minutes the epinephrine should be given ideally for the new guidelines?
Audience,
A, 5
can you?
minutes. Letter
Okay.
B, within 10 minutes. Letter C, within 15 minutes. How many minutes?
Hello, audience. Can you answer the question?
Yeah. Did I discuss it properly? What is the new guideline about the epinephrine for cardiac arrest pediatric client? We have to administer the epinephrine for the new guidelines within letter A, 5 minutes after cardiac arrest. Letter B, 10 minutes after cardiac arrest. Letter C, 15 minutes after cardiac arrest. What is your answer? Can I check on this chat box? Oh, there's no one who is answering. Did you hear me? Did you heard me to discuss that a while ago?
Halo, beliau bertanya kalau diberikan epinefrin itu berapa menit sekali? Apakah 5 menit?
5
Apakah
minutes,
1
sir.
menit?
Okay, I think they are listening. Okay, within 5 minutes. Hello, Indonesia, you have to answer. All right. Okay, to confirm if you understand the presentation. All right. Okay, the strict cricoid pressure is not recommended anymore upon intubation. Okay, next. Okay, the ROSC or return of spontaneous circulation, you have to monitor for neurological signs and symptoms, which are the seizure and convulsion after the return of circulation. Okay, another slides here. The opioid overdose management includes CPR and the timely administration of naloxone, because the naloxone is the drug against the opioid. So we have to give the naloxone for the pediatric patient who have opioid overdose, because those pediatric who had opioid overdose will include also this to the CPR management. All right. Children with acute myocarditis who have arrhythmias, heart block, ST segment changes, or low cardiac output should be transferred to ICU, because they are highly risk to have cardiac arrest. All right. So you have to transfer them for closer monitoring. All right. Another slides here. Infant and children, okay, with heart disease and single ventricle physiology who are in the process of stage reconstruction requires ALS management. Management of pulmonary hypertension may include the use of nitric oxide, prostacyclin, and analgesia and sedation. So what are the causes of cardiac arrest in children differ from cardiac arrest in adults? Okay, because there are different causes of cardiac arrest to our pediatric clients. Okay, so here we're going to discuss the chain of survival inside the hospital and outside the hospital. Okay, inside the hospital, you have two. Number one, you have to check the sky blue color, the IHCA or the ICA. Inside the hospital, you have to recognize and prevent. Okay, you have to recognize, check for the signs and symptoms of the impending cardiac arrest. Who are those? Those clients who have cardiac disorder, myocarditis, okay, ventricular septal defect, and then you have to activate the emergency response team if there is a cardiac arrest, and then perform the high quality CPR, which was discussed yesterday, advance the resuscitation, which includes your defibrillation, and then post cardiac arrest care and recovery. What about outside the hospital? What is the first thing that we have to do? Number one, we have to prevent as much as possible the occasion of cardiac arrest. Okay, we have to follow the next step, activate the emergency response team, or you have to call for help, and then start to do CPR while waiting for the ambulance. Okay, when the ambulance arrive, you have to perform the advanced resuscitation using the defibrillation, oxygen, etc., and post cardiac arrest care inside the hospital, then recovery. Okay, so this is the pediatric BLS for lay rescuers, for those who are bystanders, for those who are from community members. Okay, I'll repeat, for community members. Okay, number one, we have to instruct them that you have to check the environment if it is safe. Check the step one, gray color. Step one, make sure the scene is safe. Check to see if the person is awake and breathing normally. Okay, you have to assess. That's number one. Assess the environment and assess your client. Number two, you have to ask for help. If you're alone with a cell phone, then you can use your cell phone to call for emergency number. Okay, so while performing CPR, which is 30 compression and then 2 breaths, I repeat, while asking for help, you have to perform CPR simultaneously because you don't want to delay the delivery of the high quality CPR. Again, 30 minutes, 30 compression, 30 compression, and then a cycle of 2 breaths, a total of 5 cycles, and then get an AED. Okay, again, I repeat, 30 compression and then 2 breaths for a total of 5 cycles. Okay, for 5 cycles before getting an AED. If you don't have a cell phone, okay, if you don't have a cell phone, you can perform CPR first. Okay, you can perform CPR first, 5 cycle, and then ask for help. Okay, ask for help and get AED. If help is available, you can if help is available, you can call the 911 and start CPR while you are asking for help, because we don't want to delay the delivery of high quality CPR. Okay, so step 2, it's all about asking for help, and it's all about delivery of CPR. Again, it's 30 compression with 2 breaths, a total of 5 cycle before performing AED. And then step 3, we have to repeat the cycle of 30 compression and then 2 breaths. For the child CPR, okay, we have to push in the middle of the chest, okay, middle of the chest, at least 1/3 at the chest at the depth of 2 inches only, okay, with one hand. If the child is thin and the child is a little bit chubby, you can use 2 hands. Okay, for the infant, you have to push in the middle of the chest using only your fingers. Okay, using only the 2 fingers. This is for infant. Okay, 1.5 to 2 inch, 1.5 inches with 2 fingers, and then use the AED as soon as possible, or continue the CPR until EMS arrive. Okay, I repeat that. For the child CPR, okay, you can use one hand, depends on the body type of your client, or 2 hands. Okay, for the infant, you want only use your 2 fingers, the approximately 1 to 1.5 inches. All right, that is instruction for lay rescuer. So this one is a basic life support algorithm for healthcare providers, for nurses, for EMS, single rescuer only. So just like the previous one, the first step, the green one, the green says that we have to verify the scene safety. Okay, next slide, please. Next slide, please. Can you move the next? Can you present the next slide, please? Okay, so the pediatric basic life support algorithm for healthcare provider or the single rescuer should be the next slide. Okay, we are done to the pediatric BLS for lay rescuer. Can you please move for next slide? Or maybe there's a delay here from my computer. So the first color here is color green. Can you see it from your slide? Okay, color green, which is verifying the scene of safety. Then check for responsiveness. Hey, 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 are you okay? And then ask for help. Okay, activate the EMS response system by a mobile device. You have to call 911. Okay, hey, 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 are you okay? Please ask for help. And if you have your cell phone, you can use your cell phone. Okay, look for no breathing. Okay, look for no breathing. Check for the breathing. Remember, gasping is not a breathing. Okay, gasping is not a breathing. Okay, and then you have to check for the pulse simultaneously. If pulse is felt within 10 seconds, if there is normal breathing
and there is pulse, I repeat, if there is normal breathing, if there is pulse, you just have to monitor the client. Okay, no further action. You just have to monitor and maintain the airway pattern, airway and breathing. Okay, if there is no breathing but there is pulse, no breathing but there is no pulse, okay, you have to provide rescue breathing, 1 breath every 2 to 3 seconds. I repeat, if there is no normal breathing but there is a pulse, you can give 1 breath every 2 to 3 seconds, or about 20 to 30 breaths per minute. About 20 to 30 breaths per minute. And then assess for the pulse rate for no more than 10 seconds again. If the pulse rate of the client is less than 60, pediatric patient, and with sign of poor perfusion, okay, sign of poor perfusion, you have to start CPR. Okay, you have to start CPR. But if the pulse is more than 60, continue only the rescue breath and check the pulse every 2 minutes. If no pulse, start CPR. If no pulse, start CPR. Okay, let's go back to the arrow. If you witness, okay, if you witness that the pediatric patient has collapsed, okay, if you witness that the pediatric patient has collapsed, you have to start CPR. Okay, 1 rescuer, 1 nurse, you have to perform the cycle of 30 compression, and 2 breaths. 30 compression and 2 breaths. When second rescuer arrives, okay, perform cycles of 15 compression and 2 breaths. If you have the 2 rescuer, you can do 15 compression and 2 breaths. If you have 2 rescuer, all right, then use AED as possible. After about 2 minutes, if he's still alone, okay, if he's still alone, if only 1 rescuer, okay, you have to activate again the emergency response and retrieve AED if not already done. Okay, and then if there is an available AED, you have to check the rhythm if it is shockable or not. Okay, if it is shockable, then give the 1 shock and then resume CPR immediately after 2 minutes. I repeat, after the first shock, you have to repeat the CPR for 2 minutes. Okay, but if the patient is not shockable, resume for CPR immediately for 2 minutes until AED is allowed to check. Okay, then continue with ALS. All right. So we have a different algorithm provided with pulse. Okay, there are a lot. I also put there the components of post-cardiac arrest care. Ma'am, can you please present the slide for the components of post-cardiac arrest care? Next slide, please. Next slide, please. So okay, thank you. You can access the different algorithm. We will going to send you the material so that you can review more, because we only have 40 minutes to present. So here, this one is very important. Okay, we have to check components of post-cardiac arrest, meaning to say we have to check these after cardiac arrest of the pediatric client. So number 1, oxygenation and ventilation. What do we have to check? Number 1, measure the oxygenation and target normoxemia, meaning to say the normal oxygen blood, which is 94 to 99. That is our target. Another here, number 2, is measure and target the PaCO2 appropriate to the patient's underlying condition and limit exposure to hypercapnia or hypocapnia, meaning to say if it is over-oxygenated or poor oxygenated. So that is for oxygenation and ventilation. The next thing that you have to check after cardiac arrest is the hemodynamic monitoring. So you have to monitor the hemodynamic goals post-cardiac arrest and review it daily. Okay, meaning to say the cardiac activity using telemetry. Okay, you have to check the cardiac rhythm, you have to check the vital signs, the pulse, the BP, Okay, next you have to monitor for arterial blood pressure, monitor for serum lactate, urine output, because urine output has something to do with the perfusion of your heart, and central venous oxygenation. Okay, use parenteral fluid bolus with or without inotropes or vasopressor to maintain systolic blood pressure, getting than fifth percentile for the age sex. Okay, next we have to check also the temperature management of the patient, measure, continuously monitor core temperature, prevent and treat fever as much as possible. If patient is comatose, apply TTM followed by TTM, or we want to maintain the normal temperature as much as possible. We don't want to have shivering or hypothermia. Okay, prevent shivering, monitoring blood pressure, and treat hypotension during rewarming. Another things that we have to monitor is the neuro. Okay, neuro monitoring. If the patient has encephalopathy or resources are available, monitor for continuous encephalogram, because this is the common complication. We have to treat seizures, because remember, when there is a blood supply interruption from cardiac arrest, there might be irritation to the brain. Okay, so there might be a seizure, possible seizure for the children. So you have to treat seizure. Consider early brain imaging to diagnose treatable causes of cardiac arrest. Okay, remember that the heart and the brain is connected. So when the heart stops on pumping of blood, there will be no oxygenation on the brain. That's why we have to monitor if there's a brain damage or is there a possibility of seizure. Then electrolyte and glucose. Measure for blood glucose and avoid hypoglycemia, because hypoglycemia may exacerbate the seizure incidence. Maintain electrolytes with normal ranges to avoid possible life-threatening anemias, and also sedation. Treat with sedatives and anxiolytics if there is a need that is according to the doctor's order. And then prognosis, always consider multiple modalities, meaning to say it should be a collaborative management and other or over any single predictor factor. Remember that the assessment may be modified, okay? And consider ECG and EEG with factors within first 7 days after cardiac arrest, because we want to check if there is a damage inside the brain or complication, okay? Considering neuroimaging again and MRI during the first 7 days after the cardiac arrest. All right. So there are major new update here. How time do I have left, ma'am?
You have still 20 minutes.
20 minutes. Very good. Okay. Next slide, please. Okay, again, we want to review the major and new updated recommendation. Okay, 2020 BLS for infant. Again, the reasonable to give one breath every 2 to 3 seconds. That is equivalent 20 to 30 breaths per minute. Okay, we are reviewing now the specific changes. Again, the new guidelines telling us that we have to give 20 to 30 breaths per minute. The old one is only about 12 to 20 per minute. Okay, the old one, last 2010, is 12 to 20 per minute. But today, we are asked to give 20 to 30 breaths per minute. Next slide, please. Okay. 2020 updated, when performing CPR in infants with an advanced airway, it may be reasonable to target respiratory rate of 1 breath every 2 to 3, accounting for age, clinical condition rate. Exceeding recommendation may compromise hemodynamics. So this has been discussed a while ago because the new data showed the higher ventilation rate. Okay, are associated with improved rates of ROSC. So it says that if we are giving about if we're giving more to seconds, okay, and it should be done 20 to 30 breaths per minute, there is a good chances of ROSC. Next slide, please. Okay, another guidelines that we have been discussed a while ago. 2020, we are not using the cricoid pressure anymore. Why? Because new studies shown that routine use of the cricoid pressure reduce the intubation success rate and does not reduce the rate of regurgitation. That is the reason about it. Next, please. Okay, there has been an emphasis about the epinephrine for the new guideline. Okay, we discussed it a while ago that the epinephrine should be given within 5 minutes after the cardiac arrest. Why? Because according to study of children with inside the hospital cardiac arrest who received epinephrine for an initial non-shockable rhythm, okay, demonstrated that for every minute delay in administration of epinephrine, there was a decreased chance of survival, okay, or survival to discharge. Next slide, please. Patient who receive epinephrine within 5 minutes of CPR initiation compared with those who receive epinephrine after 5 minutes were more likely to survive. That is according to the study of the American Heart Association. So there is a big role of the epinephrine here because we all know that the epinephrine has inotropic effect and chronotropic effect. Okay, it improves muscle contraction. It improves the heart rate of your patient. Next slide, please. So, invasive blood pressure monitoring to assess CPR quality 2020. The updated for the patient with continuous invasive intra-arterial blood pressure monitoring in place at the time of cardiac arrest, it is reasonable for provider to use diastolic blood pressure to assess CPR quality. That is according to the ECG guidelines of American Heart Association. Okay, why? Because providing high chest compression in critical gives a success resuscitation. A new study shows that among pediatric patients receiving CPR with an arterial line in place, rates of survival with favorable neurologic outcome were improved if the diastolic blood pressure was at least 25 mmHg in infant. Next slide, please. So how about hemorrhagic shock? Okay, for 2020, among infant with children with hypotensive or hemorrhagic shock following trauma, it is reasonable to administer blood as much as possible instead of the crystalloid. Okay, for example, the cardiac arrest is because of the hemorrhagic shock. It is more important or more advisable to give blood rather than crystalloid. Why? Because previous version of the guidelines did not differentiate the treatment of hemorrhagic shock from other causes of hypovolemic shock. Next slide, please. So here, what is our conclusion? Effective education is key variable in improving survival outcome from cardiac arrest because without education, without giving instruction to the community, without the awareness of the community, so there will be poor management in terms of pediatric cardiac arrest even in adults. So education and awareness has vital role in saving the client with cardiac arrest. Okay, this is one, actually, it should be a collaborative effort from the government and the healthcare sector to provide education and training to the community to achieve the successful dissemination of information about the proper performing of CPR and BLS. It should be a collaborative effort by the government and health sector down to the community member. Next slide, please. I think that is the end of the presentation. I hope we learned something today. I am happy to entertain your questions.
Okay, thank you, Mr. Donar. Any question from audience?
I am so sorry for the technical problem here. I'm outside of our house because there is no electric power. I'm just using a hotspot from my cell phone as of now. I mean,
Okay,
that
okay,
internet is
okay.
from the cell phone.
No problem. It's usual problem if we get a webinar like this.
Yeah.
It's okay. Sir, I would like to ask, in pediatric BLS for life rescuer,
Mm-hmm.
how in Filipina to do this?
Okay. Actually, in Philippine setup, it is very rare it's very rare that we are encountering a patient who have cardiac arrest, because in the Philippines the major problem here is the adult cardiac arrest. So as a nurse here in the Philippines, it's very few here in our country having the cardiac arrest. But we have a series of training also. We have a series of training also about the cardiac arrest for the pediatric client. So we are familiar on how to perform because we are also active in the training and seminars about the pediatric.
Okay, okay, okay. Sir, a second question for you.
Mm-hmm.
From Pak Yandi, according to the 2020 American Heart Association algorithm,
Mm-hmm.
administer epinephrine immediately in PEA or assist patients before CPR. Epinephrine is best given before or after CPR. Thank you.
Okay, very good. The epinephrine should be given within 5 minutes after cardiac arrest. Okay,
Mm.
after cardiac arrest. So meaning to say, it doesn't matter if it is the CPR first or the epinephrine first. What matter here is the time after cardiac arrest. Okay, when you witness a cardiac arrest, make sure that the epinephrine should be given as soon as possible, as early as possible. Even you are doing the CPR at the same time, give the epinephrine within 5 minutes after the cardiac arrest. So it doesn't matter if the CPR starts or if it doesn't matter if the CPR is not start. What matters, what is the important, you have to give epinephrine after or within 5 minutes after cardiac arrest. Give epinephrine as early as possible. It doesn't matter if what comes first.
Okay. The third question, sir, from Apriyadi, from Waluyo Jati Hospital. According to 2020 American Heart Association algorithm, administer epinephrine immediately. It's the same thing, I think.
Yes.
Epinephrine is the best given before or after CPR.
Okay.
Okay.
You don't need to wait for the CPR, or you don't need to wait for anything. The epinephrine should be done alone with CPR or no CPR, because it said that we have to give epinephrine within 5 minutes after cardiac arrest. So maybe you're doing CPR now and then give epinephrine, or maybe there's one nurse who are giving epinephrine then doing a CPR. So it doesn't matter if it is CPR comes first. What matters is the time of administration of the epinephrine. It said that we have to give the epinephrine within 5 minutes after the cardiac arrest. Give it as soon as possible.
Okay. Okay. I think that is
Okay.
okay.
I want to add personal insight. For example,
Okay.
you're alone. You're alone. You're just a one nurse inside the ward. Okay, you're just one nurse, and then you saw someone who is having cardiac arrest, which is pediatric client who having cardiac arrest. So there's an emergency drug. So what will you do now? Will you perform CPR or give the epinephrine? Okay, that is a good question. What will you do first, sir? Will you give the epinephrine or perform the CPR if you are alone only, if you're one nurse only? So if you're going to ask me, I will give the epinephrine first and then do CPR immediately after giving the epinephrine. But if you are two nurses, one will give the epinephrine and then you will do the CPR. So you can give the epinephrine and CPR at the same time if you are two nurses. I am clear with that.
Okay. I think they are clear about this question. Sir, one question again.
Yes.
From Hospital Sutomo, from
Mhm.
ID Atma Bebayon ID Atmaja. Please
Mhm.
allow me to ask why at a time when CPR at pediatric for two helpers change to be 15 compression and to breath. Thank
Again, what's
you.
the question?
Okay.
Sorry.
Uh, why at a time when CPR at pediatric for two helpers change to 15 compression
Ah,
to breath?
okay, okay. I got it. I got it. Okay.
Okay.
Why there is a change, okay, from because if you are alone only, if you're alone only, 30 compression and then two breaths. 30 compression then two breaths. But if you are two nurses, 15, okay, 15 and then two breaths if you are two nurses, okay, because we are giving more. Actually, it has the same cycle, but the difference only has increasing the respiratory rate of your client. So you are administering artificial respiratory rate for your client, and there's no so much difference from the cycle.
Okay. Okay. From Bebayon Idi Atmaja. I think the answer from Sir Donald is clear. Okay, thank you, sir, for coming to webinar. And I think your time is end.
Mhm. Okay.
Okay.
Let me say thank you to everyone. If you wanted to invite me again, just go to my Instagram, Don Kim Tan Escanio. Okay, how would I write this one?
Okay, thank you. If you
Thank you very
anything activity, could you please left the webinar? Thank you, sir. See you
thank you so
again
much.
in next webinar.
See you, see you, see you, see you. Thank you very much. Regard to Dr. In and Ma'am Pratuma. Regards. Take care, everyone.
Okay. Okay. Is a presenter, first presenter for our webinar today. In pediatric BLS, I conclude this session. Pediatric BLS for life rescuer. The first we have to do instruct them danger for environment and continue with ask for help by cell phone to emergency number. And the third step is repeat cycle of 30 compression and to breath. For a child, deep 2 inches and to breath. And for infant, deep compression in 1.5 inches with 2 fingers, and AED as soon as possible it arrive, and continue CPR until EMS arrive. It's pediatric BLS for life rescuer. If you alone, you can to do 30 compression and to breath. But if you to rescuer, you can change with 15 compression and to breath. Okay. I think it's the important from Mr. Donald, but there are and something I think the same with algorithm in AHA or American Heart Association. The first is oxygenation. The important thing that we give attention. The first is oxygenation. The second in hemodynamic monitoring, and the third target temperature management. And the next step is neuromonitoring. For example, a seizure patient, and electrolytes and glucose sedation and prognosis, because we have to consider if there are multiple modalities. Oke, itu adalah kesimpulan daripada pembelajaran untuk sesi dari Mr. Donald. Yaitu yang terpenting di sini adalah diajarkan di Filipina tentang pediatric BLS for life rescue atau untuk penolong umum. Ya, penolong umum di sana atau umum, ya kan biasanya kita dewasa. Ini adalah untuk umum. Menolong bagaimana cara kalau kita menemukan anak atau bayi dalam keadaan pediatric collapse atau cardiac arrest. Ya. Pertama tetap saja kita lihat danger, ya terutama di sini adalah untuk environment. Kemudian ask for help. Yaitu biasanya kita menggunakan cellphone untuk memanggil number emergency. Kemarin sudah diberikan oleh Pak Welas berapa nomor emergency kita, kan? Kemudian melakukan kompresi dengan 30 kompresi dan 2 nafas. Ya. Untuk anak-anak, kedalaman kompresi adalah 2 inci. Ya. Ini hampir sama dengan orang dewasa. Dengan 1 tangan atau 2 tangan. Kemudian kalau bayi kedalamannya adalah 1,5 inci, kalau bayi hanya 2 jari saja. Ya. Kemudian pasang IID as soon as possible atau sesegera mungkin sampai di sana EMS arrive. Di sana dilanjutkan dengan continuous CPR. Itu kalau dilakukan oleh orang awam, ya. Oke, tapi untuk di dalam rumah sakit tentunya dilakukan oleh tenaga kesehatan. Ada algoritma yang hampir sama dengan AHA atau American Heart Association 2020, yaitu yang pertama yang perlu diperhatikan adalah oksigenasi. Ya. Kemudian yang kedua adalah hemodynamic monitoring. Ya, terus kemudian suhu, karena untuk bayi ini bagaimanapun suhu adalah sangat penting. Ya, kemudian neuromonitoring yaitu berkaitan dengan kalau pasiennya mengalami seizure dan sebagainya, yaitu tentang monitoring untuk persarafan. Ya, yang dilanjutkan dengan elektrolit dan glukosa, kemudian yang terakhir adalah pemberian sedasi. Ya, untuk ROSC itu yang terpenting di sini adalah untuk melihat cardiac activity yang dilanjutkan dengan simptom-simptom daripada neuron, simptom daripada persarafan. Ya, oke, itu adalah conclusion daripada Mr. Donald tadi. Ya, now we continue with to the second speaker, with Dr. Lee Wan Ling from University of Malaya. Hello, doctor. Are you there? Hello, Dr. Lee. Hello, Dr. Lee.
Okay.
Okay,
Thank you. I saw the
Alhamdulillah.
unmute function was not enabled. Saya tak boleh tekan-tekan unmute.
Alhamdulillah.
Okay,
Okay.
kita bertemu lagi. Ya.
Okay. Dr. Lee Wan Lee from University Malaya. The topic today is nursing care for coronary disease. Okay, please, doctor, you have 40 minutes for presentation, and I will remind you 5 minutes before the time end. Okay, please, it's your moment, doctor.
Terima kasih, Bu Musri. Good afternoon, everyone. Kita berjumpa kembali, and I take this opportunity, to extend my salam sejahtera to rakan-rakan pendidik yang berada dalam platform ini, juga kepada jurawat-jurawat, ya. Saya semua ni jurawat-jurawat, ya, yang sudi meluangkan masa di petang Ahad ini untuk bersama-sama menimba ilmu pengetahuan. Syabas, ya, saya ucapkan. Right, so what I'm going to talk about is today basically coronary care, nursing care of coronary patient. Just give me a moment, saya buka slides sekejap, ya. Okay, how is it? Is it okay?
Yeah, okay. Okay,
Okay.
Doctor.
All right, okay, thank you. All right, saya mengambil kira, I take into consideration that the audience are not just cardiac background nurses, betul, tetapi ada jurawat daripada pelbagai lapangan yang lain, kan? So what I'm going to do is I will address this topic, from the perspective when a nurses work as in a general ward. Now, you see, when you work in the general ward without, it's very common for you to come across patient with coronary heart disease. So what I'm going to share with you is very much general overview. And then if for those nurses from the cardiac background, if you would like to have more in-depth information, we can have that more sessions during the Q&A, or you can also email me. Okay, so let's begin. So nursing care of patients with coronary heart disease, sometimes it's also known as coronary artery disease, okay, ischemic heart disease, and they are all mean the same. So generally, what is coronary heart disease? Basically, make it simple, it's a disease due to the blockade of the heart blood vessels. So what block the heart blood vessel is the plaque ateroma. Okay, adalah macam plaque yang mempunyai unsur lemak. So we call it plaque ateroma, and it happens by progressions. And you know that the coronary artery disease, what I'm trying to say, if the coronary arteries is being blocked, so it cannot supply blood to the myocardium, and that's where the muscles of the heart will suffer, will have inadequate oxygen, become ischemia, and if it's prolonged, they will have necrosis, which lead to infarction. So that is very much general what it means by general coronary heart disease. Is my voice clear? Is my Wi-Fi okay?
It's okay. I know, Doctor, it's clear.
Okay. Right. Now, what actually causes coronary heart disease, CHD, short form of CHD. I get tongue twisted, so long name. Okay. What actually causes CHD? The actual causes, the precise causes, they have not really been determined definitely. However, there is substantial amount of studies that has been shown to prove these are the risk factors that contributing to the progressions, to the developments of atherosclerosis. As you can see from here, now the most important risk factor, the common risk factor, strong risk factor, will be those, for instance, the family histories, okay? And then, of course, age, okay, male, but these are non-modifiable factors. You can't do much about it. However, what is become the focus of care among us would be look at the patient's modifiable risk factor. Patients with hypertension, right? These are very strong risk factors. We can slow down the development of CHD if we help our patients who already a known case of hypertension to control their BP. and those with diabetes. These are a very strong risk factor. So much and so they even said that if a person's have diabetic, the doctors already start treating them as though they develop CHD. So you'll find that very common patients with diabetic, some of them already started on statin, and some doctors are moving into that line because they find that a huge proportion of patients with diabetic eventually down the line, along the many years, they will develop CHD. And of course, those with dyslipidemias, with a high cholesterol, high triglyceride, high LDL, these are the people would at risk of developing atherosclerosis. And smoking also been known. Yes, smoking is also a strong factor contributing to CHD because it has been found that when you smoke, you have caused the chronic damage to the endothelium of the blood vessels that making the plaque atheromas easily to stick on the endothelium and form these atheromas. And of course, obesity and too much consumptions of fatty food will also put a person at risk. Now, there are many others. Actually, there are a lot of other risk factors. But what I'm putting here is just the common one. So when you work as a nurse, be it in a clinic, primary health care, or in a maternal ward, or where you are, if you come across patients who are smoking, high blood pressures, diabetes, right? Okay, obesity, then you should start actually have that kind of conversation telling them, hey, you know, you need to sort of control, these are the risk factors contributing to CHD before they're developing CHD. Okay? Prevention is always better than cure. Right. Let me see. Somebody is pointing. What is this line coming in? This line. Let me see. I can erase this. There's a line there. Yeah. Okay. Right. Somebody sort of draw something on it. Okay. Anyway, let me show you what is actually happening in the blood vessels. You will see that at the very beginning, the blood vessels is cantik, clear, clean. There is no plaque atheroma. But however, if we do not manage those risk factors, then you will see that the atherosclerosis begin the process. The plaque atheroma begin to deposit on the blood vessels, and then this plaque can eventually grow, become increase in quantity, become bigger and bigger. The plaque atheromas will become bigger and bigger. So when this the symptom will depend on how much the blockage occur. So very common at the very beginning, you know, the plaque atheroma is already there, but you find the person asymptomatic because there is no significant severe blockage that causes a significant reduction of blood flow to the myocardium of the heart. So therefore, the person feel they're okay, they don't have symptoms, they don't have chest pain. But that's the thing lah. They continue with the unhealthy lifestyle, and the plaque atheromas continue to build more. And then when later on, when they become quite substantial, they will start to have a stable angina. Stable angina is meaning that this kind of typical angina, chest pain, it occurring when they are exerting. When they go for that, you know, larian pecut, marathon, or very intensive exercise, then they feel a bit chest tightness. And when they rest, it goes soft. It is because at that time when a person exerting, let's say they're running fast, so the myocardium oxygen consumption increase. But when the blood flow, through the coronary artery is not enough to meet the oxygen demand of the myocardium, so that's where, you know, there is a deficits of oxygen supply to the myocardium, and that's trigger the chest tightness and chest pain. But once a person rests, the oxygen consumption myocardium goes down and met the supply, met the demand, therefore pain gone. So it's pretty stable. The thing is, the tricky part about plaque ateroma is they are not stone. They become batu. You know, it's not like a batu karang you throw to the wall will crack. It's actually a living cells. Yeah. And what happened to these living cells is sometimes it can rupture. Okay. As it goes more and more, okay, the symptom will be more severe. But the most common, should I say, event happening, yeah, leading to a person having a sudden chest pain will be where the plaque ateroma is ruptured. Where's the plaque ateroma ruptured? When it's ruptured, as you know, it will attract aggregation of platelets and form, okay, the thrombus, blood clots. This is where, okay, the thrombosis, this is the commonest. Of course, there are other events like vasospasm. I'm not going to go through that because they are not common. The most common, more than 90%, is due to thrombosis. So when that happens, okay, the person will start to have a cardiac event, which we call it as ACS, the commonest ACS. So what is ACS? Acute coronary syndrome. The acute coronary syndrome is a medical diagnosis. It referring to a heart conditions resulting from a sudden reduction of blood flow to the heart. Right? And then why there's a sudden reduction is because when remember when the plaque ateroma ruptured, okay, the thrombus, you know, the thrombus can get bigger and bigger. If the thrombus is small, the occlusion is not that bad. But if you're not doing anything about it, the thrombus formation, the thrombus can get bigger and bigger, and then the blockage becomes significant. Yeah. So you will see, right, this is stable angina. You have a plaque, but your ECG will be kind of normal, right? Then when the plaque ateroma become significantly big, and then when there is a small rupture, there is a formation of small thrombus. What happens is you will see there will be an ST depression. A common one will be the ST depression here. Okay, right. ST depression, right? But okay, the ECG also can be normal. Okay, sometimes they are very hard to detect, but you will see that the person will have chest pain. Okay, the person will have chest pain, but when you do a cardiac biomarkers like troponin, okay, troponin, it will be normal. Your CKMB will be normal, your troponin, because what happened here is there is no myocardial, or there is no ischemia or necrosis of the myocardium. Okay, so it's called unstable angina. So from here onwards, it's already called acute coronary syndrome. Right? So acute coronary syndrome, a person can present to you with unstable angina. This is very hard, and they will come to you classical chest pain. It can be normal, there could be ST depression, but you'll find that, okay, the troponin is not elevated. However, when the thrombus is getting a bit more bigger, the occlusion become more severe. Okay, there will be a partial ischemia of the myocardium. The partial thickness of the myocardium be affected. Then you will find the troponin T, the cardiac biomarkers start to elevated. Yeah. However, you will still find that the ECG, it can look normal, but there's no ST elevation. Key thing is there's no ST elevation. That's why it is known as non-ST elevation myocardial infarction. In other words, this is a small heart attack. Right? A small heart attack. Right? There is no ST elevation, but the troponin T is raised because there is some muscle damage happening. Now you know the troponin T comes from the myocardium. So when the myocardium being damaged, all right, okay, injury damage, so it will lysis, the cell will lysis and pour out the content. That's where you get the troponin, the cardiac biomarker flowing in the bloodstream. Then, of course, the severe one will be the STEMI. STEMI stands for ST elevation myocardial infarction. These are full thickness, okay, of full thickness infarction. there is a myocardium infarction, there full thickness. This is classical. You will see ST elevation, typical ST elevation like this. And definitely you will see a raised cardiac biomarker such as serum. Right. So recap, acute coronary syndrome is diagnosis referring an acute event that's happening due to thrombosis. Stop. Yeah. So this is thrombosis. The severity of the thrombosis will determine the type of acute coronary syndrome. So the mild one, the most mild type of acute coronary syndrome will be unstable angina. Right. The middle one of mild heart attack, because this is not actually considered heart attack. Yeah, it's just unstable angina. When the mild heart attack, we call it as non-STEMI, okay, where you will see troponin T raised by the ECG, no ST elevation. And the last one will be the classical full-blown heart attack that we know as ST elevation, myocardial infarction, and where you will see typical ST elevations, you will see the raised troponin T. Of course, in all of these, they will have chest pain. Okay. They will have chest pain. They have risk factors of CHD. Okay, that clear with that. Right now, I'm aware of time. All right, so 15-minute pass. Okay, heart attack between men and women. What I do because of time constraint, this topic actually is being covered 3 or 4 hours. I'm going to concise it into 40 minutes. So I'm going to leave the slides with Ibu Musri. You can read it. I assume some of you already well versed about this topic. Now you can see that the men and the women, they are slightly different. Okay. Obviously, if you see from the TV, the person will have chest pain, you know, centrally, like prosternals, they can radiate to the left side, to the jaw, to the back. All right. And then they have shortness of breath, right? They feel like nausea. These are very typical, like you see in the TV. Women's sometimes can be a little bit more atypical, because most of the time women at that time is old. They did a study and they find that there's slight variation. You know, sometimes the women will complain a bit fatigue. Their chest pain is not so classical, but they complain fatigue, they complain indigestions, right? Fatigue meaning sangat penat lah, tak tentu pasal penat. Yeah? And then another one, so for women, if you see a woman come to you, they don't come to you like a classical chest, not that kind of chest pain. Like you see in the TV, they just come to you, I don't feel good, I feel indigestion, I feel extremely tired, I feel like dizzy. And then you look them there, she's also a diabetic, you know, a hypertension, something you must ring a bell. Huh? Same thing goes with diabetic patient. They don't come to you that kind of typical presentation, because a lot of diabetic patients have neuropathy. So they don't, right? They're very common. They don't come to you that with classical chest pain. Yeah, they come with you with all this kind of vague symptoms. Just be aware. All right, now this to show you what is actually the pathophysiology of happening during the ACS. And besides here, I will tell you the rationale of treatment, how these treatments correspond with the pathophysiology that's happening. So there's a risk factor. Then you know that to develop CHD or ACS, then you need to have a risk factor. You know, even young people don't have risk factor, no hypertension, no diabetic, you know, sweet 18, sweet 16, sweet 17 come to you, complain of chest pain, you wouldn't think of CHD. You would think of something else, okay? Putus cinta ke, gaduh dengan girlfriend ke, all right? But definitely not CHD in your first mind, right? So you need to know that if a person comes to you with chest pain, look into the risk factor. We will talk about that a bit more, right? So in terms of the treatments would be that anything, you know, in you, you help the patients to modify the risk factor. That will certainly slow down the progression of atherosclerosis, right? Then when there's a plaque atheromas, will cause narrowing of the lumens. Okay, depends on how narrow it is. When the plaque ruptured, there is a platelet aggregation and thrombus formation. So during that acute event, the immediate treatment will be do something to prevent further platelet aggregation. So that's why antiplatelets is very important, because antiplatelets will minimize platelet aggregations. Okay, We do not want to form thrombus in a very fast, okay, big and fast. We do not want that to happen. That's why very often that you see, we will give them stat, aspirin, right? Then another thing is if there is a thrombus formation being formed, okay, you need to have a drugs to break the thrombus, to clear, okay, the blood vessels from the blockage. So you will find that the doctors will administer antithrombotic, fibrinolytic. This is to break the thrombus. Then when there is a critical, when this thrombosis is significant, there would be a critical, narrowing of the blood vessels. Kesumbatan yang critical. When that happens, blood flow will be severely affected. Kuranglah, blood flow almost zero. Right, then there you will see myocardium will have necrosis. And if the little bit blood flow still flowing but not enough to meet the myocardium consumption of oxygen, you will have ischemia. But you know the ischemia, if you don't do anything, from ischemia it becomes necrosis. Therefore, you will find it very common at that time. You will give sublingual GTN because you want to vasodilate, open up the diameters of the blood vessels. And sometimes you will give sublingual GTN. Or if the BP is also high, they will also like to have an IVI nitrate, the IVGTN, isosorbide dinitrates. These are the common nitrates. And when there is a critical, myocardial ischemia, necrosis, there will be chest pain, of course, pump failure, heart failure. They come to you failure. So you probably hear doctors, diagnose a patient come with CLIPS 2, CLIPS 3. These are their lingo, their language. And they will have dysrhythmias. And this is the one that, suddenly patient just collapse. Now, why patient collapse, you see, is because of the VT or VF happening at that time. So very important is when there is ischemia, you need to give an oxygen. You need to give oxygen. At least increase the oxygen supply to the blood. You need to make them rest. Sit down, rest, complete rest. Don't go to toilet. Get rest. Then when there is a pain, you need to treat them with morphine because the pain is really severe and is real. You need to have a potent analgesia that will be morphine. Right, then definitely you need to have a continuous ECG monitoring because of this danger. In the first 24 hours, this is the one that we always worry. When I nurse a patient during acute coronary, having either unstable angina, STEMI or non-STEMI, they're always at the back of my mind, dysrhythmia. Because I have many times the patient will smile to you, ear to ear, senyum-senyum, then out of the blues, they just collapse, right? They just develop VT out of the blues. That's why continuous ECG monitoring is very important. And your defib must be next to it. You have an ECG monitoring, but no defib, you have problems. Because most of the time, you would have to give defib. Now, and then slowly, when they already pass the danger phase, we start to prevent cardiac remodeling. So we do not want the heart become out of shape. So you have to optimize it with drugs. We talk about that ACE inhibitor and angiotensin. We'll talk about that more. And then we will slowly put them into rehabilitation, which I already talked about cardiac rehabilitation, which is very important. That a lot of us do not seem to emphasize it enough. Okay. Right. So it always, a good nursing always start with an assessment. You can't run away with it. So you need to look at the history taking because a very good history taking will help to answer 2/3 of the inquiries. Physical examination, investigation results. Right. So what do we normally, as a nurse, what do we normally assess? Number one is first thing first, always back again, risk factor. Look at a person, non-hypertension, non-diabetic, non-active smokers, is it overweight? All right, what else? OH, male gender, ethnicity, certain ethnicity are prone to it. Family history. So when you have all these risk factors coming together, then it really is more supportive of your suspicions that this patient are really having a ACS. And when they come to you, you need to see whether they have sign or symptom of cardiac output reductions, like shock. Do they come to you in shock? right? I presume that you know more about it. So these are the things when you have a patient come to you, chest pain, look at them. Do they show sign and symptom of shock? Do they show some symptom of acute heart failure? And this acute heart failure is due to the cardiopulmonary congestions. Time constraint, I can't really tell you actually how does when the heart fail to pump effectively, it has that backlog phenomenon flow leading to the congestions of the pulmonary system. Yeah? So the patient will come to you, shortness of breath. Yeah? And then of course, myocardial infarction, where the classical one will be pain. So these are the important assessment. Here, I will list up to you, if you want to know whether a cardiac output is good enough, you look at the blood supply. And when the heart pumps, it eject blood out, so that's called cardiac output. And then if it's eject enough cardiac output, meaning that it's enough blood supply to the brain and to the vital organ. So if the cardiac output is not good, there is not enough blood supply to the vital organ. So if it's not enough blood to the CNS, you see these symptoms. If it's not enough blood supply to the kidney, you will have polyuria. Not enough blood supply to the skin, you see the skin become pale, cold, and the capillary fill time more than 2 seconds, right? And the person will have tachycardia compensation mechanism, and of course, the person feels fatigue, right? These are signs and symptoms of shock. Okay, I won't go through it. I think the previous lecture already covered it. And this is a sign and symptoms of acute heart failure because of cardiopulmonary congestions. These are symptoms of pulmonary congestions. Yeah? Typically during the acute pulmonary syndromes, it's more of a left-sided. So very typically they come to you breathless. They can't lie down. Yeah, they're autopnea, they're breathless. Okay, assessment of chest pain is important. Right, so we can use the PQISG approach. So what does it stand for? It's an acronym. When I move this down a bit, okay, it's an acronym. Next page. Just give me a moment. Okay, all right. Okay, where does it go? Sorry, I'm moving out. Okay. Right, so the P stands for what actually make it worse, provocative and palliative. Ask the patient, okay, what did you do that causes the pain? What did you do? What provoked it, make it worse? Of course, you ask that, what would you do? Especially as a patient, okay, they will say, when I do like this, the pain get less. The palliative, meaning what the person discover that the pain will go down. So ask about that, and then the quality of discomfort. Okay, where does it? How is it like? Is it like a crushing, pinprick, elephant stepping on my chest? This kind of description. Yeah, regions where it is located. Is it electrosternus or sometimes epigastric? They were pointed at the gastric region, right? Does it radiate? So get all this information. Severity, how bad it is. Is it mild, moderate? You have the pain score. And then is it temporal, meaning that it's temporary? So these are the things that you can ask to find out, okay, a little bit more information about how bad is the chest pain. Okay, now, so, and I have about 30 minutes already passed. Now, the next one, I will go fast. These are the overview that I have shown, that I've shared regarding the coronary artery disease. Let's get down to the real thing, that is nursing care. So I assume that you will come across, you work in any ward that you are in, you are bound sometimes a patient in the middle of the night, especially when you work night shift. In the middle of the night, you will have patient come to you with chest pain. And then probably you have to manage one ACS in your night shift or in one of your duty, yeah, or even in the clinic. So what are the basic nursing care? I'm in Malaysia, we normally use NANDA, nursing diagnosis. Have you heard of North America nursing diagnosis, NANDA diagnosis? So you will see that my approach is using the NANDA nursing diagnosis. However, whatever approach that you use in your setting, maybe some of the principle you can take note and apply. Okay, right. So here, there are many problems actually. When you nurse a patient that is having an ACS, I'm talking about ACS, yeah, because if they're not ACS, they don't come to the ward. Okay, they're at home. So when they come to the ward, they're having ACS. I went, so if they're having ACS, there are many problems. So I would just focus on 4 salient problems. Salient meaning these are the ones that are common, important, significant, dangerous. Yeah. So number 1 will be acute pain. Number 2 will be the risk for decreased cardiac tissue perfusion. And I choose the third one, anxiety, because they are so real, so common. Now, when you get a heart attack, the fear is real, right? It can exacerbate the myocardial ischemia. And the last one is effective health self-management, because at the end of it, when we help the patient pass the critical, dangerous phase, so what next? They need to know how to take care of themselves so they don't come again with another attack. Right. So let's go down to the first one. It's an acute pain. So if you can go to the website and learn more about NACA diagnosis if you're interested to use that approach. So here, what happened is the way we form diagnosis, we have the problems, okay, acute pain. So what causes actually the problem? It is related to critical occlusion of coronary arteries, leading to ischemia and necrosis. So this is the cause, because there are many reasons causes acute pain, right? But here it's due to the occlusions, okay? Penyumbatan salur darah coronary menyebabkan ischemia myocardium. And what are the evidence? That you will say that patient will have pain, usually more than 4. And then they have the autonomic responses like, they become sweaty, tachycardia, they feel nausea, all the symptoms that you have seen, become pucat. Right. And then this is a pain scale that we use to ask a patient to quantify how bad is their pain. So 4 will be somewhere around here. Okay. All right. Okay. But a bad one can go up to 8 and 9, okay. They'll be very distressed. So we have a problem. Once we have a problem, then we also have an objective expected outcome. So when we nurse a patient, we have an expected outcome. We expect that, whatever we do, we hope to bring down the pain within 30 minutes of starting the drug therapy. Yeah, 30 minutes. You don't let them pain prolong for 2 hours, 3 hours. They will develop neurogenic shock. Okay? So
Hello, doctor. Hello, doctor. Your voice is have a problem. Hello, doctor. Okay. Hello, doctor. Your voice is have a problem. Oh, Dr. Lee keluar Zoom. Oke. Okay, for all audience, hope to be patient because Dr. Lee out of the Zoom. We wait a moment.
Isn't it amazing how almost every line on our hands align? When your hands are mine, it's like I'm whole again. Isn't that a sign? I should speak my mind. I've said those words before, but it was a lie. You deserve to hear it 1,000 times. If all it is to say that, why is it so hard to say? If all it is say that is why am I in my own way? Why do I pull you close and then ask you for space? If all it is say that is why is it so hard to say? To say
Okay.
Coming for you in the fast lane, got me all fired up, full gas tank. Put the pedal to the floor when I hit the dough. Give me everything you got, like the bank is out. Yeah, you pull up in a Lambo, that drip that shit like candles, and I lose my grip with the handle, and I choose you over the bando. You keep my engine on fire, you could never guess what how you move around the cars, make me ooh. You got the thing that I want, know your love hit the spot, and you never should stop, baby.
사랑은 불장난 같다 하지만 난
Coming for you in the fast lane, got me all fired up, full gas tank. Put the pedal to the floor when I hit the dough. Give me everything you got, like the bank is out. Yeah, you pull up in a Lambo, that drip that shit like candles, and I lose my grip with the handle, and I choose you over the bando. You keep my engine on fire, you could never guess what how you move around the cars, make me ooh. You got the thing that I want, know your love hit the spot, and you never should stop, baby.
사랑은 불장난 같다 하지만 난
Kasih andai anganku bermuara, ia akan bernyanyi.
Mungkin kita berjanji, jari manis jadi saksi
bahagia.
Kulihat ada yang bersinar di kedua bola matamu.
Unmute.
Hello.
Okay, all right.
Hello, doctor.
Okay, all right. Aduh,
Okay,
saya kena
okay.
pakai hotspot. I don't know what happened to the house Wi-Fi. Okay, I just. Aduh.
We have always faced the problem if use technology. Okay, you
Okay.
can continue your subject, doctor.
Saya just skip. Okay. Okay, right. Maaf ya, maaf atas masalah teknikal, masalah Wi-Fi ya. So I'll make it fast, make it simple, and then I will leave the notes. You can read that. So here I have all my rationale. Mana saya punya? Okay, so I have here the rationale for each of the intervention. If you have a patient, if you work in anywhere, you are in anywhere setting, if you come across a patient that you suspect could be having an ACS, first thing is sit down, rest. Make them get lie down, CRIB, and then give oxygen. Okay, these are the things you can do immediately. Give oxygen, and then document the chest pain. Ask them about their chest pain. They find out whether they have risk factors. And then you don't need to wait for doctors. You can initiate 12-lead ECG. Straight away do a 12-lead ECG, I mean, all the nurses should be trained to do a 12-lead ECG. And then when the doctors come, and then assist the doctor to take blood, okay, to take blood for cardiac biomarkers, to check for troponin, CKM. Then, of course, when the ECG come out, if it's so typical, classical ACS, we will start drug therapy straight away already. So you will find that the doctor will prescribe aspirin, chew stat, ask them to chew, right? Give them a sublingual GTN and IVI nitrate, especially if the BP is high. And then we will give them morphine if they have a severe pain. Now, if they are in other ward or other setting, you need to consider transfer them to CCU. I think a patient with ACS should be nursed in CCU for many reasons. Number one, the nurses will be there to be trained to do a lot of things, to give drugs, to debriefe, and make independent decisions. And they have the setting that is uniquely of CCU. Now, in some setting, they combine CCU and ICU together, whatever it is. If your patient is in a general ward, maternal ward, consider preparing them to transfer to the coronary care. And then the doctors, remind the doctors to get the cardiologist on call to come in to attend the patient. And my reminder to you, if you transfer the patient, don't transfer by yourself. It must be follow along the doctors. You have to make sure patient is being hooked to an ECG monitoring, because along the way, when you're transferring patient, they can just suddenly collapse, develop VT, VF, So you need to have continuous ECG with defibrillator, and then have an airway equipment standby in case during the journey you have to intubate. Well, not you lah, the doctors have to intubate, right? Oxygen therapy, definitely full tank, make sure full tank oxygen therapy and resuscitation drugs. And so you are transferring a very critical ill patient. They might smile to you, but they're ill. Then typically, we would like to start as soon as possible. It's confirmed diagnosis, especially it's a confirmed diagnosis of STEMI. We would like to start fibrinolytic therapy, like streptokinase. Gentle reminder before the doctor start the streptokinase or the nurses start to prepare the streptokinase, get the doctors to insert 2 granula, 2, okay, 2, not just 1. The reason is, 1, you already given the streptokinase, and then suddenly that line bang, rosak, suddenly bang, you cannot go and chuchuk, because you already started the streptokinase. You cannot give sub-Q injection, IM injection, or prick the patient, because if you do, you will have a massive hematoma, huge bleeding. Patient will bleed, big hematoma. And so don't do that. Get it all. Make sure that IVF patents are both ready. Then only you start your streptokinase, and then observe them for bleeding and continue ECG monitoring. For non-STEMI and unstable angina, we normally do not want to consider streptokinase, we will consider antithrombolytic like low molecular weight heparin. Like, have you heard of Clexane, enoxaparin? And these are the drugs we given and to prevent further thrombosis, because the thrombus is not that big, so we will prevent further thrombosis with this drug. It will prevent further development of thrombosis. The body itself will break the thrombus. But however, in the STEMI, the thrombus is so big, you cannot wait for the body to lyse it. You have to give a drug to break it immediately. Yeah, that's the rationale. And then if for whatever reason, after streptokinase, the pain is not getting any less, the ECG is getting worse, then some of the doctors will say, okay, let's go for rescue PCI or primary PCI. PCI meaning percutaneous coronary intervention, right? So we have to prepare for that. And this is how a PCI looks. They will go to the lab and straight away open up the blood vessels in the lab. And when they open up, you will see a good results. Yeah, this is before and after. Okay. All right. Problem number 2. Decreased cardiac output. Decreased cardiac tissue perfusion, meaning that the heart muscles are not getting enough of the supply. So what we do? Yeah, number 1 is what can cause us it? Because number 1, the cardiac tissue do not enough perfusion, meaning blood supply, so receiving blood supply. So the cardiac tissue do not get enough blood supply because there will be inadequate blood flow. Okay, and sometimes reperfusion injury. This is something a bit advanced. Reperfusion injury is very common because when there is a blood vessel block, so there is no blood supply to the other end. And when you open up, so when the blood flow, suddenly the areas be flooded with blood means of blood. So there is all the free radicals that's being pour out into the blood streams and then causing injury to the nearby cells. So you will see that sometimes after streptokinase, you will see this reperfusion arrhythmia. These are very common. Okay, we call it reperfusion injury. Sometimes that can happen. So patient will have chest pain, abnormal ECG, as well as autonomic responses and cardiac output reduction. So this is what we expect, right? Let's move to, because of time constraint, let's look at what are the actions that we can do. So we have to continue monitor the oxygen saturation, continue, even though they breathe normally, I still insist that they will put on their nasal prong oxygen therapy, yeah? Then continue to monitor the ECGs, right? And monitor the chest pain, right? Continue to do that. Yeah, somebody scribble on the screen. Okay. All right. Then next. Another important thing is standby defibrillator by the bedside. This is very important because in the first 24 hours, number 1 danger would be arrhythmias. Patient develop VT, VF. So you need, if it's pulseless VT or VF, the treatment would be you have to defibrillate as fast as possible. The earlier, the better the outcome. Then you have to obtain the 12 ECG as per protocol. So you finish your streptokinase, you have to repeat an ECG, and then you do an ECG again serial. This is our protocol. And then every time when the patient complains of chest pain, we will do ECG. So in one time, sometimes we do a number of ECG. So we always, in each ECG tracing, we will put the date and the time. So we can see the transitioning of the ECG pattern. And very importantly, so consider, optimize the medication, administer cardioprotective medication. So patient will be put on antiplatelet like aspirin, ACE inhibitors. ACE inhibitors stands for angiotensin converting enzyme inhibitors. So if you heard drugs like lisinopril or the pril, they belong to ACE inhibitor. Sometimes if a patient is sensitive to ACE inhibitor, a little bit more expensive, abang kepada ACE inhibitor will be the angiotensin receptor blocker, ARB. So if you hear drugs like Vasartan, Losartan, these are the angiotensin receptor blockers. And these drugs, it's important drugs because it prevents the heart remodeling, meaning you want to maintain the shape of the heart. We do not want the shape of the heart to be run out, and then patient after a heart attack, eventually they develop chronic heart failure. You want to avoid that. Right. So if you have any patient come to you with symptoms of unresolved chest pain, Okay, chest pain is still ongoing, and despite the drug therapy, and then the ECG is not so fantastic, then you have to act fast. Okay, notify your doctors to take action. This is a very basic. Okay, this is very basic. Okay, these are very basic, right? Nursing measure that we do. Okay, but do not take it for granted. Basic, it's nothing very high tech about it, but very important.
My apologies, doctor. Your time is up. Hello, doctor. Hello, Dr. Lee. Halo. Halo. Okay. Okay. While we wait, Dr. Lee, I will read the conclusion of the. Okay, wait a minute. Okay.
Coming for you in the fast lane, got me all fired up, full gas tank. Put the pedal to the floor when I hit the dough. Give me everything you got, like the bank is out. Yeah, you pull up in a Lambo, that drip that shit like candles, and I lose my grip with the handle, and I choose you over the bando. You keep my engine on fire, you could never guess what how you move around the cars, make me ooh. You got the thing that I want, know your love hit the spot, and you never should stop, baby.
사랑은 불장난 같다 하지만 난
Oke, sambil menunggu Dr. Lee masuk, akan saya sampaikan ringkasan daripada atau kesimpulan daripada apa yang telah beliau sampaikan, yaitu bahwa coronary heart disease ini bisa dialami oleh semua orang dengan faktor resiko yang bisa dimodifikasi dengan yang tidak dimodifikasi. Yang bisa dimodifikasi contohnya obesitas, hypertension, dan sebagainya. Kalau yang nggak bisa dimodifikasi itu antara lain ya keturunan, gender itu tidak bisa dimodifikasi. Oke. Biasanya kalau vascular disease ini bukan penyakit yang secara tiba-tiba, tapi ini adalah terjadi atau berkembang sejak usia dini, yaitu sekitar 20 tahunan. Jadi teenager yang tidak hidup sehat akan menyebabkan kejadian ini. Sebentar ya, ini
Dan Dr. Lee.
Ya, terima kasih. Sebab saya tak boleh unmute my function.
Oke, Dr. Lee telah kembali. Oke.
Okay.
Now we go to continue with Q&A.
Oke.
Oke, dokter?
Boleh.
Oke.
Sebab masa Q&A lah straight away. Saya akan tinggalkan nota-nota ni kepada Ibu Musri. and then kita I mean untuk benefit the audience lah. Oh sorry ya sebab
Okay.
technical
It's
problem.
okay, Doctor.
Hari ini saya kurang bernasib baik.
One question from Nusantara Building Industry, Aga Taufik. He asked how we give intervention in anxiety patient while cardiac arrest present.
Okay. Actually my next slide. Tapi thank you so much for asking that question. Adalah peluang saya bercerita sedikit tentang.
Yes, Doctor. Please.
Yes, it's very, very, very so real. I mean, if you really see a patient having heart attack, you can see their face, written that with fear. So, soalan dia, apakah intervensi kita semasa menjaga pesakit yang mengalami anxiety? Betul? Soalannya?
Betul.
Okay. I think the most important thing is the nurses must penampilan kita. Bila kita jumpa patient, the first thing is, we empathetic. Okay, you pay attention to them. Jangan tinggalkan patient. Okay, don't leave them alone. Okay, for whatever reason, get somebody to be there. Kalau you perlukan, you get your attendants to be there while you go and get doctors. Don't leave them alone. Okay, give them the assurance that you are looking into that, and give them that you know what you do. All right, and just be warm. Okay, whatever they ask, okay, answer the question. Don't just keep them aside. That is a very, very important beginning. And then keep on telling them, yes, we are doing something, this is what is happening. And then whatever you do, sometimes, sebab saya pernah jadi pesakit, sometimes I see the nurses and doctor come, buat ini, buat tu, buat ni, buat tu, tapi mulutnya kunci, tak cerita apa-apa. Sometimes it is good to explain to the patient as you nurse the patient. I'm going to put this oxygen, this little clip on your finger is to detect your oxygen level. I'm going to put this ECG is to see your heart rhythm. This is a monitor heart rhythm. If you hear the beeping sound, that is not for you to worry, it is for me to worry us. These are the things that can alleviate their anxiety. Of course, there are many more, and my notes will have all the rest of the information. But these are immediate intervention that we can do. Very crucial.
Okay.
Thank
Okay,
you for the questions.
we are going to second question from Timur. From Timor Leste. Okay, please, Mr. Ade. Mr. Adelino.
Hello.
Okay, I'm sorry. Okay,
Thank
please
you.
it's your time
Terima
to
kasih, Bu.
question. Okay,
Terima kasih.
sama-sama.
Hello, Dr. Lee. How are you?
Hi. Encik Adelino ya. Apa khabar?
Nice to meet you from Timor Leste.
Hi, nice to meet you too.
Yeah. Hope to meet you last month, but unfortunately we went to Malaysia. To Mara.
Come
To
again.
UITM. to UITM.
Okay, next round datang UM
Sure.
Okay.
I just want to confirm something from you regarding the clinical assessment. But it links with the data. I mean, no, not the data, but the early symptoms. You were mentioning that the early symptoms began on early 20s. Is it?
What happened is, wow, there is a data. In my early years when I'm young.
I haven't finished my question, Doctor. Sorry. Can I just continue?
Yes.
Yeah. I just confirmed that one with the clinical assessment. I just confirmed that one. I just confirmed that the case began on early 20s, and then you were mentioning on the clinical assessment, nurses should focus on the cardiac output status. So my question is linked with the early happening when we do the clinical assessment. Is it focus after somebody being diagnosed with the CHD, or in the early 20s we can do already to get the symptoms? I mean, in before that one.
What a good question, Encik Adelino. Very good question. Very timely, because we believe prevention is better than cure, betul? So in the early 20s, in fact, as early as possible, kalau ada risk factor, you see in the young people, those young people who already start smoking, we should start telling them, hey, you are at risk of getting heart disease, right? Those young ones, even now at the early 20s, if you see the young people don't have a healthy lifestyle, they smoke, right? They eat fatty food, they don't exercise, they're obese. These are the people that you will start to advise them, hey, you start to do something about your lifestyle, because if you don't, you already start developing atherosclerosis in the heart of the blood vessels, already start. So therefore, prevention, okay? Now,
can we notice the symptoms, doctor? Can we notice the symptoms?
Most of them, unfortunately, they have no symptom. That is the problem with heart disease. At the beginning stage, no symptom. That's why people will continue to smoke, continue to eat burgers. Burgers. Sekali-sekali burger okay lah. Tapi they continue with their healthy lifestyle because they don't know symptom. They don't believe it. They don't believe already atherosclerosis already building inside because it's kan penyumbatan dia sangat sedikit, sangat minimal, tak ada simptom. Cuma by the time 30, 40, then dah penyumbatan become ketara, then they to start to have symptom. Tightness bila dia exert. At that time, it's a little bit too late lah to reverse back. Okay, the progression. So once dah teruk, dia terus teruk. So you kena lambatkan. So assessment kita basically very important is risk factor. Very beginning risk factor, educate, and tell them to go for it. But I'm telling you, kita sekarang ni ada patient with heart attack as young as 21 years old, 22 years old. Yeah. Last time we only see those yang 40 tahun, 50 tahun. Sekarang I come across those early 20s get heart attack. Okay. So that is one thing lah. Okay, assessment of their risk factor, one. Okay. Then another thing is when I talk about the assessment is when you have someone that come to you with suspicious of ACS. You rasa this is really related to jantung. You rasa dia ada a cardiac event. You suspect dia ada acute coronary syndrome. Tapi you tak tahu, it could be unstable angina, it could be STEMI, it could be non-STEMI. So in that situation, how do you assess? Number one is, I will go back again, tengok dia ada tak risk factor, one. And then number two, I tengok kan seteruk mana penyumbatan. Because penyumbatan yang teruk, that akan menyebabkan jantung, bila jantung tidak menerima bekalan darah yang cukup, dia akan start to not pumping well. Dia tak pump dengan well. Because tak cukup. You know, the jantung to pump, dia perlukan bekalan darah yang mengandung oxygen. When they don't receive that, they don't pump that good. Cardiac output drop. So the first thing I see, the sign or symptom of any reduction of cardiac output. Kalau cardiac output dia okay, I tak begitu risau. Meaning that, masih boleh bertahan. Tapi kalau dia sudah menunjukkan tanda-tanda kekurangan cardiac output, like a bit restless, peluh-peluh sejuk, okay, and then you tachycardia, lepas tu you tengok dia punya jari dia sejuk, okay, rasa skin, skin, in my pengalaman rasa touch the skin. Bila tengok skin tu sejuk tu, I will say that already in shock. When they're already in shock, okay, because of reduced cardiac output, that's where you know anytime they can collapse. Because I pernah patient smiling, berpeluh-peluh, just collapse in front of me. Okay, so these are the assessment yang crucial. If you come across anybody, they come to you chest pain, okay, look for risk factor, look for whether they ada reduction of cardiac output, and look for the other tanda-tanda shock. These are the things, because when they have, then it gives you the urgency, okay, the urgency to act.
Okay.
I hope I answer your question. Thank you for the
question. Thank you, doctor. It's clear. Thank you.
Thank you, Mr.
Terima kasih, Bu. Terima kasih, Bu.
Okay. Maybe we continue with one question again, Doctor. From Santi Heti. Okay, Ibu Santi, saya persilahkan. Ibu
Apa
Santi
khabar,
happy?
Ibu Santi? Ibu Santi kena unmute.
Oke, Ibu Santi, halo, still unmute.
Mungkin tak boleh unmute kot.
Oke, boleh ditukar dengan mute.
Admin kena unmute.
Oke, kalau tidak ada, dokter kita akhiri sekian untuk pertemuan kita. Mungkin dokter ada sesuatu yang ingin disampaikan?
Okay. Terlebih dahulu saya ingin sekali lagi minta maaf, dibuat maaf ya, technical error. I tak tahu kenapa hari ini saya kurang bernasib baik. Wi-Fi semalam okey, hari ini tak okey. Lepas tu ada pula meragam semi elektrik, lepas tu putus, aduh. Okay, but what I hope that actually topik ni actually it's important sebab apa, bila you pergi ke ward, you buang je batu, you sure dapat ada patient yang ada hypertension, ada diabetic, ada coronary artery disease. Wherever you are, okay, this is a crucial knowledge as a nurse. And I will send you the notes so that you can read the notes, and feel free to contact me. I'm apologize that I'm not able to deliver as much as I possible due to time constraint and unfortunate circumstances. And I thank you so much kepada Ibu Musri dengan penganjur daripada Universitas Unjani menjemput saya untuk berkongsi pengalaman. I'm enjoying myself. Thank you so much, and we hope to see you again. If you come to Malaysia, come and contact me. All right.
Okay. Thank you, Doctor.
Thank
Bye.
you so much.
Okay. Jumpa lagi, Dokter. Oke, bye-bye. Saya akan bacakan kesimpulan daripada pembicara Dr. Lee, yaitu untuk coronary heart disease, yaitu ini merupakan vascular disease ya, yang merupakan satu penyakit yang progresif yang mulai berkembang di usia teenager dari umur 20-an sampai akan timbul tanda dan gejala di usia 40 sampai 60 tahun ya. ACS ini ada beberapa macam, yaitu ada stable angina, unstable angina, ada end-STEMI dan STEMI. STEMI ini merupakan yang terberat daripada penyakit ACS, ya. Disebut dengan silent heart attack or typical presentation among person with diabetes mellitus. Cardiovascular risk factor ini mendapat dimodifikasi atau dapat diterapi sesuai dengan simptom yang ada. Kemudian untuk fokus assessment untuk kardiovaskular ini itu bergantung kepada berat gejala, tanda dan gejalanya. Tapi yang penting di sini kita bisa mendapatkan tentang riwayat penyakit dan physical assessment untuk pasien dengan heart disease ini. Biasanya yang sering muncul adalah chest pain yang bisa kita kaji dengan menggunakan PQRST, ya. Biasanya ini secara teori dan yang sering kita dapatkan di klinik biasanya akan muncul acute pain atau nyeri akut, kemudian faktor resiko untuk terjadinya gangguan perfusi, ya, gangguan perfusi pada jaringan kardiak, ya. Kalau ini di emergency atau kita temukan di poliklinik hal-hal yang demikian, maka kita akan langsung biasanya rujuk ke CCU, ya. Di CCU sekali lagi dalam refer to ruangan intensif ini kita tidak boleh sendiri, tapi kita harus ada lebih dari satu orang. yaitu kalau ditransfer ke CCU, yaitu dengan menggunakan oksigen tentunya ini tidak boleh ketinggalan ya, dan airway equipment. Oke, ya. Untuk di ruangan CCU-nya seharusnya memang di CCU adalah orang yang sudah atau perawat yang sudah mempunyai keahlian untuk penanganan jantung. Saya rasa itu kesimpulan daripada apa yang disampaikan oleh Dr. Lee Wan Ling. Saya atas nama beliau memohon maaf atas kendala atau hal-hal yang tidak menyenangkan tadi, ya. Okay, we will continue with third session by Professor Dr. Pratuma. Okay, hello, Doctor.
Hi, good afternoon.
Good afternoon.
Technical problem.
I don't know. I don't know. Today,
Yes.
every speaker have a
Yeah, I hope I
problem.
won't make a technical problem. Also.
Yes. Okay. I hope you running well.
Yes, right.
You will running well. Okay. Prof. Pratuma, as a third speaker, the title her presentation today is Update Cardiac Arrest Management and Post-Cardiac Arrest for Maternal and Newborn. Doctor, you have 40 minutes for presentation, and I will remind you 5 minutes left, and you can start now. Please deliver your speech now, Prof.
Okay. Thank you very much for your introductions. Okay. Today is our second day. I think we know this. Okay, wait a minute. Okay. Okay, good afternoon again, everybody. Today I will present updates cardiac arrest management and post cardiac arrest for maternal and newborn. Yesterday, I already told you that author BLS and ACLS recommendation in pregnancy remain same in both 2015 and 2020, and its similarity with the CPR among adults. Some activity needs more among pregnancy during CPR, such as left lateral position to relieve compressible compression of the inferior vena cava. LUL or polymordium cesarean section. Cardiac arrest in pregnancy effect allow 1 to 30,000 women, and the risk of death for mother and child is extremely high, but some cases of cardiac arrest are reversible. Aggressive resuscitation is required, including cesarean section. In most cases, over 20 weeks gestation. The importance of rapid delivery after cardiac arrest for maternal benefit is becoming a widely accepted practice. This is outline for today. CPR in pregnancy needs return of spontaneous circulation, such as clear sign of life, including breathing, coughing, or movement, or maybe blood pressure, or presented of arterial waveform with intra-artery monitor and an abrupt and sustained increase in expiratory carbon dioxide measure. About the patient management, the PMMR, the model is good that we would like to provide services to patients, and we can provide wonderful benefit services to patient well. The 2020 AHA CPR and ECG guideline indicate that the following interventions are important in managing maternal cardiac arrest. All of following should be performed to be high collaborative obstetric, neonatal emergency anesthesiology, and ICU and cardiac arrest services. That's why if you would like to manage well of collapse patient, maybe you should collaborate this model well. If we would like to provide a good maternal fetal outcome, you should follow up critical care in labor, including prevention of concurrent complication, early recognition of the problem, prompt aggressive intervention, and then it will have good maternal fetal outcome. The 2020 guideline are a complicated revision of the ASA guideline for adult pediatrics, neonatal resuscitation education science, and system of care topic. They have been developed for resuscitation provide and ASA instructor to focus on the resuscitation side, and guideline recommend that you should study, and then you can provide for patient in your organization. In this presentation, I summarized management and services and post resuscitation from this guideline, and Royal College of Obstetrician Gynecologist, maternal collapse in pregnancy and puerperium, neonatal resuscitation, and European Resuscitation Council Guideline 2020. They are similar and related to support pregnant women during CPR. This European Resuscitation Council has produced this newborn life support guideline also, and cover the management of the term and preterm infant. The topic cover include an algorithm to aid a logical approach to resuscitation of the newborn, factor before delivery, training and education, thermal control management of the umbilical cord after birth, initial assessment and categorization of the newborn infant, airway and breathing and circulation support, communication with parents, consideration when withholding and discontinuing support. You can study, it's very good paper also. Yesterday, I also mentioned that major new and update recommendation in pregnancy. This after CPR, the new guideline recommend target temperature management for pregnant women who remain comatose after resuscitation from cardiac arrest also. And 2020 mentioned that during targeted temperature management of the pregnant patient, it recommended that the fetus be continuous monitored for bradycardia such as potential complication, and obstetric and neonatal consultation should be sorted. This is for the post CPR. For this is adults, the enhanced for adult basic and advanced life support. They would like to 2020 would like to enhance algorithm and visual aid, provide easy to remember guidance. You already studied yesterday. And the importance of early initiation of CPR by lay rescue has been de-emphasized. And they would like to, they recommend continuous measurement arterial blood gas pressure and tidal carbon dioxide during ACLS. Resuscitation may be useful to improve CPR quality. On the basis of more recent evidence, routine use of double sequential defibrillation is not recommended, and intra-IV access is the preferred use of medication administration that ACLS resuscitation. IO access is acceptable if IV access is not available. You can get medication to those way. How about the adult basic and advanced life support related to pregnant women? Care of the patient after ROSC require close attention to oxygenation, blood pressure control, evaluation of percutaneous coronary intervention, targeted temperature management, and multimodal neuroprognostication that you should monitor. Because recovery from cardiac arrest continue long after the initial hospitalization, patients should have formal assessment and support for their physical, cognitive, and psychological needs, like Donald and Dr. Lee says, after a resuscitation debriefing for rescue EMS provider and hospital-based healthcare worker may be beneficial to support their mental health and well-being. After CPR, maybe they stay in ICU or hospital long time. We can help them to over the bad situation. Okay, this is the adult post cardiac arrest care algorithm. You can obtain and then manage airway, manage respiratory parameter, and manage hemodynamic parameter. Normally, this management is in ICU, and we should read ECG and consider for emergency cardiac intervention if STEMI patient unstable and mechanical circulatory support required. This is for adult, women, pregnant women is adult also. That's we apply this to implement during after resuscitation. This the figure is number 8 in AHA 2020 recommend approach multimodal neuroprognostic patient in adult patient after cardiac arrest for 24 hours, for 48 hours, and 72 hours. You should monitor like this. Follow this protocol. For example, like airway, secure the airway with early placement and endotracheal tube. Breathing target, we need oxygen 92 to 98% and carbon dioxide 35 to 45 mmHg. And we start ventilation with 10 beats per minute and titrate FiO2 for circulation such as target systolic blood pressure more than 90 mmHg and mean arterial pressure more than 65 mmHg. And we administer IV fluid and consider vasopressor and inotrops, and we obtain 12 lead EKG. Yeah. To be reliable, neuroprognostication should be performed no sooner than 72 hours after return to normothermia. And prognostic decision should be based on multiple mode of patient assessment. In 2020, guideline evaluation 19 different modality and specific finding and present the evidence of its a new diaphragm present this multimodal approach to neuroprognostic. About the post-cardiac arrest, that 2000 guideline contain significant new clinical data about obtained care in the day after cardiac arrest. You should study. And about care and support during recovery. Yesterday, you also learned from Dr. Lee also, but I would like to mention again that 2020 guideline recommend that cardiac arrest survivor have multimodal rehabilitation, assessment, and treatment for physical, neurological, cardiopulmonary, and cognitive impairments before discharge from the hospital. Guideline recommend that cardiac arrest survivor and their caregiver receive comprehensive multidisciplinary discharge planning. Not only nurse or physician, we should collaborate multidisciplinary career, and is would like we can integrate with medical and rehabilitative treatment recommendation and return to activity work expectation. Guideline recommend structured assessment for anxiety, depression, post-traumatic stress, and fatigue for cardiac arrest survivor and their caregiver. Last presenter, I saw some question that what are the intervention to reduce anxiety or something like that. Maybe it depends on your religion and your culture. From this in some paper that they show post-collapse management. If patient alive, we inform coroner, procurator, physician from MBRAC. And maybe we continue treatment under cause of collapse, transfer to appropriate clinical care setting high dependency of critical care unit, and be sure that accurate documentation, debrief patient if alive and relative, offer staff support and debriefing and review case to clinical government process. This now we have many protocol for post resuscitation. For this slide, I present. I would like to show about when pregnant women stay with complication. You should do situation awareness perception that maybe they will have some problem about the high risk, and you should SA comprehension such as what has happened and what is happening, and you should have question what might happen that you can protect and reduce the serious condition will. For CPR for pregnant women who have a cardiac arrest or maybe maternal collapse, maybe after CPR they will the newborn go to NICU and the patient, the pregnant women go to ICU. We should try to conduct intervention to help them to recover well. And you know that if pregnant women, you should do the left lateral, maybe, and maybe when you CPR them, it's very useful that it can reduce, it can reduce compression of the inferior vena cava and give, you must give 100% oxygen. You should know that your ward or your organization should provide immediate 100% oxygen well and establish IV access above the diaphragm access for hypotension. And we should consider reversible cause of clinical illness and teeth condition that may contribute to clinical deterioration as early as possible. That's why the team CPR must have experience. I know that adult CPR team is could not familiar the pregnancy women CPR, but their ability, their performance in pregnancy will. A2S etiology of maternal cardiac arrest. That's you know that you will think more about A2S, and then you can protect and prevent the serious situation among pregnant women. About the physiological change in late pregnancy women is very serious. That's blood volume and cardiac output increase by 18th week, and focus must always be on resuscitating the mother, not the fetus. We propose in the mother 500 milliliters of blood per minute enter the uterine circulation. Pregnancy is very susceptible to hypotension from compression of the IVC in the supine position by the enlarged uterine. The enlarged uterus cause evaluation of the diaphragm by about 4 centimeters and result in a decrease in the functional residual capacity by about 20%. This change that you know that in hospital about adults, yet you should do early recognition of and prevention early and sudden cardiac arrest. The activation of the emergency response system, high quality CPR, early CPR with an emphasis on high quality chest compression, defibrillation, and post cardiac care and recovery that you should conduct the program in your hospital. This is continue. Yesterday we already told you that this CPR. For updates cardiac arrest management for maternal in your hospital, you should call maternal code blue. You should set the theme of maternal code blue. Avoid aortic caval compression. Initiate high quality chest compression. Do not delay use measures such as defibrillation and imitation of medication. Donnell also told you, the first presenter also told you that defibrillation and drug imitation also. Pace intravenous access above the diaphragm. Assume the patient had a difficult airway. Pregnant women have very difficult to do about the airway also. Estimate that the gestational age of the fetus use the entitled carbon dioxide monitoring. About code blue dash identify respiratory cardiac arrest about nursing skill. Activate code blue and you can do oxygen administration nasal cannula or mask with back resuscitation with 100%. If you can apply mask with back is good. If you found maternal cardiac arrest, monitor defibrillation pass application intravenous access medication administration and defibrillation ACLS training and CPR documentation. Maternal code blue. One person should immediately start high quality CPR at compression to breathe. One person should manage her airway, provide ventilation with back valve mask and intubation, and manual LUD to help ensure proper blood flow to the heart. One technique and two technique depend on the situation. And about the updates, cardiac management for maternal, priority for pregnant women in cardiac arrest should be high quality CPR, relief, aortic compression, and the onset of the cardiac arrest in pregnant mother invisible the fetus in danger. Fetus that are beyond 33 weeks in gestational are considered viable and doctor can consider to perimordial cesarean section. Yet after 23, some paper mention that 20 weeks. The delivery of the fetus through this method will result in the stabilization of the mother because arteriovenous compress caused by Gowes uterus stop. Perimordial cesarean section should be conducted in 5 minutes of cardiac arrest. Maybe it start the 4 minutes and we should finish in 1 minute. Yeah, depending on the result of skill set of provider. A difficult airway is common in pregnancy, so use the most experienced provide in ET tube and supraglottic S1 airway. Perform from capnography or capnography to confirm and monitor ET tube placement. One S1 airway is in place. Give 1 beat every 6 seconds with continued chest compression. About the MCPA, cardiopulmonary arrest, step 1, rapid assessment of gestational age. This paper mentioned 20 weeks. Step 2, displacement, the LUD. Step 3, yes, immediate initiation, basic life resuscitation support and ACLS, including defibrillation. Step 4, performing polymordium in 4 minutes. Allow for resuscitate delivery within 5 minutes. Step 5, evaluation of the primary etiology of maternal cardiac arrest. Okay, this is for the estimate about gestational age. Maybe if you study midwifery, maybe you study maternal nursing, you can know that about the umbilical is 20 weeks. Okay, and then up to the 26, 30 weeks, and then is an engagement and lightening after 36 weeks. About the update cardiac management, it dedicates timer perimordial cesarean section that you should. I know that you came from some hospital that you didn't have gynecologist or obstetrician. Maybe it's very hard to do perimordial cesarean section, but it's the strategy intervention that recommend to do in at 4 to 5 minutes begin perimordial cesarean section. Yeah. Perimordial cesarean section prognosis for intact survival of infant is best if delivered within 5 minutes of maternal arrest. Go to remove fetus and continue resuscitate of both mother and fetus. If we move newborn from mother, it's very good that we can CPR outside the mother. During the procedure, maternal CPR had to be continued. Vertical midline abdominal incision from 4 to 5 centimeters below xiphoid. Proceed to this beneath to vertical line and insert to the fascia and muscle into the peritoneum. after 15 minutes of unsuccessful resuscitation, initiation direct cardiac massage, if appropriate resource and personal nurse could not do, we need physician. Thoracotomy and open chest massage are particularly effective for patients with chest trauma, tension pneumothorax, massive pulmonary embolism, pericardial tamponade, and chest or spine deformity. Thoracotomy may also facilitate treatment of the underlying cause of the arrest, such as removal of pericardial fluid, thrombosis, or something like that. This picture open cardiac massage is performed with two hand high technique. The clapping motion sequentially close the hand from palm. This picture Strategic clamp is used to clamp the pulmonary hyrum for hemorrhage control or to prevent further bronchovenous embolism. Maybe after 50 resuscitation. In the event of collapse, maternal resuscitation in UK mentioned that the guideline of maternal collapse should follow this. If maternal cardiac arrest occur in community setting, basic life support should administer and rapid transfer arrangements. Manual displacement of uterus to the left effective in relief aortic valve above women 20 weeks. A left lateral tilt of the women from head to toe at an angle 15 to 30 degrees. In ASA didn't mention that, but UK guideline mentioned that we should put something at the right side, 15 or 30 degrees on the film surface will relieve aortic valve compression in the majority of pregnant women. In case of major trauma, the spine should be protected with spine board before any tilt of applied. In absence of spinal board, manual displacement of uterus should be used. Intubation and unconscious women with a cup endo ET tube should be performed immediately by experienced anesthesia. If they could not, maybe if we wait long time, maybe it's difficult to do ET intubation. Supplement high flow oxygen should be administered as soon as possible to counteract rapid deoxygenation. And bags with mask. About nerve, we can do mask with bag, and it's 100% oxygen flow is very good for patient. If the airway is clear and there is no bleeding, chest compression should be comment immediately. Okay. This is the protocol from UK. There should be aggressive approach to volume replacement, although caution should be exercised in the air contact, preeclampsia or eclampsia. Abdominal ultrasound by skill operation can assist the diagnosis of concealed hemorrhage that we can the same defibrillation energy level should be used in non-pregnant women at the same area, and we can do defibrillation. There should be no alteration in algorithm duct or dust used in the resuscitation council protocol. About the duct, you know well if you work in emergency room and you follow the your council, your country council. Common reversible cause of maternal cardiopulmonary arrest should be considered throughout the resuscitation process. Resuscitation effort should be continued until decision is taken by consultant obstetrician and consultant anesthetist to discontinue resuscitation effort. This decision should be made in a consensus with a cardiac arrest team. This is the medication, resuscitation medication, and you can study more about the category and maybe about the effect and maybe the consequence from the duct. About when we do CPR among women, the maternal maybe have a problem complication from CPR, such as liver resurrection, uterine rupture, hemothorax, and hemopericardium. And we should try to do the effect of them. Fetal complication include cardiac arrhythmias from maternal defibrillation and ACLS duct, central nervous system toxicity from ACLS duct, and arterial uteroplacental blood flow from maternal hypoxia, acidosis, and vasoconstriction. Maybe we try to keep their life, but maybe sometimes it have the negative consequence. Post-cardiac arrest care, hypothermia can be used safety and effective in early pregnancy without emergency cesarean section. We should think more about hypothermia. No case in the literature of this paper report that the use of therapeutic hypothermia with perimordial cesarean section. Therapeutic hypothermia may be considered on individual basis after cardiac arrest. Is a comatose pregnancy patient based on current recommend for the non-pregnancy patient. During therapeutic hypothermia of the pregnancy patient, is recommend that the fetus be continue monitor for bradycardia and potential complication. About the care and support during recovery in 2020, they mentioned that cardiac arrest survivors have multimodal rehabilitation asset and treatment for physical that I already told you. And care survivor and their caregiver receive comprehensive multidisciplinary discharge planning and structure assessment anxiety that you should consider more and pay attention. About the neonatal resuscitation and post resuscitation, this guideline you can study more. It designed for North American healthcare provider who are looking for up-to-date summary for clinical care. The sign of neonatal resuscitation apply to newborn infant transition from the fluid-filled environment to warm and air-filled environment of the birthing room to the newborn in the day after birth. In circumstance of the alternate or impaired transition, effective neonatal resuscitation reduce risk of mortality and morbidity rate. You can study more, and this after you CPR, you send them to the NICU. You should take care of them well. Approximately 10% of newborn require assistance to breathe after birth. Newborn resuscitation require training, preparation, and teamwork. When the need of for resuscitation is not anticipated, delay in assisting a newborn who is not breathing may impede the risk of death. Therefore, every birth should attend by at least one person who primary responsibility in the newborn and who is training to begin PPV without delay. A risk assessment tool that evaluation risk factor present during pregnancy and labor can identify newborn likely to require advanced resuscitation. In this case, a term with more advanced skill should be mobilized and present a delivery. In the absent list, certification up to half and baby require PPV may not be identified before delivery. Maybe we didn't know that we should have some effort, and you can review from this table and many table that you should apply. This is the picture that present the position responsibility during neonatal CPR. Airway initial step, support spontaneous. Okay, yeah. Breathing, PPV if apnea or bradycardia, CPAP, or supplement oxygen if labor breathing or low oxygen saturation. C. Yes, C. Circulation, chest compression. This person to do chest compression, duct and adrenaline, something like that. We should have some staff. Wonderful team. This is the picture that when we take care the neonatal, we should think about warm, clear airway, ventilation, intubation, and medicine. Warm, we should preheat warm and warm towel, temperature sensor, and plastic bag. It's very easy that we apply plastic bag to prevent hypothermia and thermometers. About the care area, breath sharing, patient aspiration, and ventilation, we use stethoscope, flowmeter, term, and laryngeal, many instruments. Then you should prepare to when you resuscitate newborn or neonatal ward. In 2020, AHA released this brochure about neonatal resuscitation. There's impact. There's anticipate upper preparation that approximately 10% of newborn need health breathing and 1% of newborn need resuscitation. About umbilical cord. Umbilical cord management, most newly born infants do not require immediate cord clamping or resuscitation and can be evaluation and monitored during skin and skin contact with their mother to birth. Temperature management, skin to skin contact after birth can be effective to improve breastfeeding, temperature control, and blood glucose stabilization. About the step of non-vigorous newborn with meconium stain, you should follow this step, and we use laryngoscope and then we suction the meconium. About the IV and IO access, umbilical venous catheterization is the preferred technique in the delivery room for baby who require vascular access to infuse epinephrine and volume expansion. IO access is an alternative. We can do IO.
My apologies, Dr.
Okay.
Prof.
Okay,
You
5
have
minutes.
5 minutes left.
Okay.
Thank
About
you.
cessation of resuscitation newborn after delivery who do not respond to 20 minutes. 20 minutes of resuscitation if have low link survival, and we should discuss with the team about this. Okay, this is neonatal support. Neonatal resuscitation require anticipation of preparation for provide. You should prepare the material. And about the pulse oximetry is used guide oxygen or something like that. You should, I don't know, I know there's some limitation of hospital that maybe sometimes you could not have enough instrument to help them. And about the chest compression, you know well, we have 2 time and 1 time, and we can do 20 minutes of CPR. And even anticipate and cord management. You know well, that's about the, we don't early to cut cord, and skin to skin matter. If they didn't have any serious condition, we should apply for skin to skin. Anywhere some newborn attend in NICU, we should enhance them to live together with the mother, and maybe we should enhance breastfeeding in preterm labor. And about the oxygen therapy and this umbilical vascular access and umbilical and volume. I already put this is the picture that you can see. Yes, did we use a plastic bag to protect temperature, and we should incubator, and maybe you should have syringe or something like that to enhance them. This is the good paper also that you can study more. Is applied to present in this paper, and it is book that I already tell you in the yesterday. Yes, post resuscitation care, prolonged PP glucose level, and unintentional hypothermia. Yes, you need you know well about the hypothermia. Specific problem among newborn: sentence cyanosis, pneumothorax, hypoglycemia, congenital diaphragm hernia, gastro-cytic Lobrin sequence. Okay, this is the quick review, and I put some information of thermal control. You can study more how to protect them and how to conduct environment and temperature at birth. And I summarize some NRP 8 edition practice reinforced for PPV and umbilical cord management in this PowerPoint. I think the organizer will send to you via this conference. Oxygen administration and chest compression CPR. The worker who work in ICU, you know well about the how to CPR baby. It's not yesterday we also talk about the CPR. Okay, medical epinephrine, and post resuscitation care, optimal dose, route, and time of surface stand in at-risk newborn, including less invasive meditation technique. Indication for therapeutic hypotonia in baby with SIE and in those born in less than 36 week gestational age. Adjunct therapy and optimal management and optimal rewarming strategy for newborn. Okay. It's okay. This is teamwork. How when you CPR baby, you should have the wonderful teamwork. Okay, thank you very much. Okay. Oh, I hope I will visit Bomo again. I really miss your country. Okay. Thank you very much. Okay.
You are welcome, bro. Okay, we continue with Q&A. Okay. Oh, raise hand.
Okay.
Please, the lady first ya, Pak. Okay, Ibu Darni Anti, please. What is your question? Ibu Darni Anti?
He didn't answer. He didn't hear. I don't know.
Okay, okay. Kalau dia belum jawab, continue with Pak Munawir. Pak Munawir, please. Giving your answer.
No. He
your
not.
question.
He showed the symbol. Yeah.
Okay. Oh, Pak Munawir, Bu Darni. Okay, we go first to the chat from Farida Aryani. How long can the baby survive in the uterus if the mother has a cardiac arrest? How about this question, doctor? How long can the baby survive in
How long can the baby survive the uterus? Yeah. We normally we should terminate after CPR 5 minutes.
Oh.
Yes, and about CPR the women 20 minutes. Yeah.
Okay. How long the born if the mother has no sign of ROSC?
ROSC. How long to born if the mother has no sign? To born. I didn't know the exactly number. Maybe some people told, after count to 10 in Thailand. If we teach student pregnancy women count to 10, you should come to hospital immediately. About the women didn't have a cardiac cardiac arrest. If cardiac arrest, we should terminate in 5 minutes.
Okay.
You understand?
Okay.
Yeah. Maybe you explain more for you. Yeah.
Okay. Oh, many questions for you, bro.
Yes, I think so. Why they didn't work in a pregnancy area? Why they ask a lot?
Because your internet is no problem. Okay. The second one, I ask about CPR in pregnancy. During CPR, patients should tilt on the left side. Is it allowed during CPR? Healthcare professional use artificial CPR like Lucas Auto Plus. Thank you very much.
I didn't know about Lucas. What could you explain more? Auto Plus.
Okay. During CPR, patients should tilt on left side. Is it allowed during CPR? Healthcare professional use artificial CPR. CPR.
Do you have a machine or AI to do artificial CPR?
Maybe like this.
No, normally when I study, we use the real man to CPR and we 30-15 degree, and we stay at the left side of the mother of the pregnancy women and we do CPR.
Okay.
I didn't know more about the artificial CPR. What is it?
Belum ya Pak ya, belum sampai ke artificial CPR. Okay. Okay, raise hand. Somebody raise hand. Ibu Darni, is it okay? Ada di sana? Atau Bapak Munawir? Ada pertanyaan?
The participant didn't familiar with pregnancy women. Yes, that's why they interested. Yeah.
Okay. Doctor, I think it's up for your time. So thank you so much for coming to the webinar, and hope in the next we can see you again, Prof.
Yes, maybe we see you again in บันดุง
ขอบคุณค่ะ
บ๊ายบายค่ะ Goodbye.
Bye-bye.
See you later.
Thank you. See you later. Oke, itu tadi adalah dari Prof. Pratuma. Mungkin akan saya sampaikan beberapa kesimpulan yang materi yang telah disampaikan oleh Prof. Pratuma, yaitu Principle of Critical Care, prinsip pada critical care pada in labor, yaitu adalah mencegah terjadinya komplikasi dan mengetahui problem-problem apa yang akan terjadi sehingga kita sebagai tenaga kesehatan boleh melakukan intervensi secara bagus, secara agresif ya, sehingga hasilnya adalah baik untuk ibu maupun baik untuk bayinya. Saya rasa itu ya. Kemudian untuk update recommendation untuk pregnancy untuk tahun 2020 ini adalah yang terpenting targetnya di sini adalah manajemen temperatur untuk pasien-pasien yang mengalami kehamilan ya. Kemudian untuk post cardiac arrest-nya tetap kita mengikuti untuk guideline yang dari American Heart Association, yaitu untuk mengoptimalkan ya perawatan optimal untuk setelah terjadi serangan cardiac arrest gitu ya. Saya rasa itu adalah hal yang terpenting daripada presentasi daripada Prof. Ratuma, yaitu perawatan mulai dari pregnancy sampai postpartum, ya, baik kepada ibu maupun kepada anaknya. Untuk CPR tadi ada guide tertentu untuk pasien hamil, yaitu dengan miring 30 derajat. Ya, kemudian dilakukan CPR. Kemudian untuk bayi pun ada aturan tertentu untuk bayi, tapi hal yang perlu diperhatikan pada bayi ini adalah terutama adalah temperatur dan oksigennya. Kenapa di sini temperatur? Karena bayi itu 80% komposisi tubuhnya adalah cairan, sehingga kalau terjadi temperatur yang tinggi itu bisa menyebabkan bayi mengalami gangguan. Saya rasa itu adalah kesimpulan yang bisa saya sampaikan daripada Prof. Pratuma. So we continue with next session from Mr. Ii from Harapan Kita Hospital. Halo Bapak Ii.
Halo.
Halo, alhamdulillah sudah sampai di sana. Semoga internet lancar jaya ya Pak ya.
Insya Allah.
Tidak ada gangguan. Oke, Pak Ii adalah praktisi dari practitioner from Harapan Kita Hospital. He's a head of INCAVIN, Ikatan Kardiovaskular Indonesia. Okay, please, Mr. E, you have 40 minutes of a presentation, and I will remind you 5 minutes left. Okay, please deliver your speech. Silakan Pak Ii. Mangga.
Baik, hatur nuhun Ibu. Ya. Tadi saya sudah diperkenalkan rekan-rekan semuanya, mengingat waktu sudah mau menjelang malam, jadi kita langsung to the point ya.
To the point,
to the
Pak.
point. Okay. Tadi sudah diperkenalkan, tapi saya akan memperkenalkan dengan sebuah pantun. Pergi memancing menggunakan kail.
Ah, cantik.
Tidak sengaja umpannya tertinggal di atas kabin. Perkenalkan, nama saya Ii Ismail. Tentunya dari organisasi yang bernama INCAVIN. Rekan-rekan semuanya, INCAVIN ini adalah
badan kelengkapan dari Persatuan Perawat Nasional Indonesia yang memiliki kekhususan dalam bidang kardiovaskuler. Untuk itu, bagi rekan-rekan yang di wilayahnya belum terbentuk yang namanya Ikatan Para Perawat Kardiovaskuler Indonesia, mau terbentuk, silakan japri aja, atau rekan-rekan ada yang mau ditanyakan terkait materi yang akan saya sampaikan, mungkin karena keterbatasan waktu, rekan-rekan silakan japri di 0813 8000 9221. Baik, sekarang kita langsung masuk ke dalam inti materinya. Pada kesempatan ini saya dapat tugas untuk membahas bagaimana tata laksana terkait takiaritmia dan bradiaritmia. Sebelum kita fokus ke dalam materi takiaritmia dan bradiaritmia, kita sedikit mengulang bahwa EKG yang normal itu yang dikenal dengan EKG sinus rhythm memiliki karakteristik. Yang pertama memiliki irama yang teratur, yang kedua memiliki frekuensi jantung 60-100 kali per menit, yang ketiga gelombang P-nya normal, di mana gelombang P selalu diikuti oleh kompleks QRS, kemudian PR intervalnya normal, yaitu 0,12 sampai 0,20 detik, kemudian kompleks QRS-nya juga normal, 0,06 sampai 0,12 detik. Atau biasanya untuk memudahkan kriteria normal pada kurva EKG itu, bagaimana mengetahui gelombang P yang normal jika tinggi atau lebarnya kurang dari 3 kotak kecil? Bagaimana memahami PR interval yang normal jika jaraknya 3 sampai 5 kotak kecil? Bagaimana memahami kompleks QRS yang normal? Berarti jika kompleks QRS lebarnya kurang dari 3 kotak kecil. Jadi semua serba 3. Kemudian yang terakhir, semua gelombangnya sama. Contoh rekan-rekan yang bisa dilihat di gambar EKG ini, di mana ada gelombang P diikuti oleh gelombang R dan gelombang T. Pada gambar di bawah ini tidak ada Q dan tidak ada S. Dan ternyata itu tidak bermasalah karena kompleks QRS itu tidak harus lengkap. Ada gelombang Q, ada R, dan ada S. Minimal ada salah satu gelombangnya tetap namanya itu kompleks QRS. Oke, kita lanjut sekarang ke dalam aritmia. Nah, saya mengutip definisi aritmia atau pembagian aritmia berdasarkan prognosisnya. Jadi kita sering menemukan aritmia di lapangan itu yang dikenal dengan aritmia minor. Yang ini yang tidak memerlukan tindakan segera karena tidak mengganggu sirkulasi. Jadi ketika pasien mengalami aritmia, tentunya hemodinamik bagus, pasien juga tidak ada keluhan. Dan pasien dengan aritmia minor ini bisa aja hanya diobservasi atau dipulangkan kalau misalkan setelah hasil observasinya tidak ada masalah. Yang kedua, aritmia mayor. Yang ini yang dapat menimbulkan gangguan penurunan curah jantung. Aritmia mayor ini identik dengan pembahasan yang akan kita bahas di sore hari ini, di mana bradikardi dan takikardi ini salah satu yang termasuk ke dalam aritmia mayor. Kenapa? Karena berisiko mengalami penurunan curah jantung dan dapat berlanjut kepada aritmia yang mengancam jiwa, sehingga memerlukan tindakan segera atau terapi. Jadi kata kuncinya rekan-rekan, aritmia mayor maupun aritmia minor ini terjadi pada pasien-pasien dengan nadi karotis yang masih teraba. Nadi karotis masih berdenyut dengan adekuat. Sedangkan yang dikatakan aritmia yang mengancam jiwa, ini yang memerlukan resusitasi segera. Berarti nadi karotisnya sudah tidak teraba, ya. Berarti memerlukan resusitasi segera. Baik, kita lanjut. Aritmia juga berdasarkan frekuensinya bisa dibagi menjadi 2, ada yang dikenal dengan bradiaritmia jika frekuensi jantungnya itu di bawah 50 kali per menit. Jadi rekan-rekan bedakan dulu pemahaman, biasanya kita mengatakan oh yang disebut bradikardi itu kalau frekuensi jantung di bawah 60. Nah, tapi yang dikenal dengan bradiaritmia itu yaitu yang frekuensi jantungnya di bawah 50. Karena kalau kita ketahui cardiac output itu struk volume kali frekuensi jantung. Ketika frekuensi jantung di bawah 50, siap-siap pasien akan mengalami penurunan curah jantung. Tentunya disertai dengan keluhan. Kemudian takikardi yang seperti apa yang bisa menyebabkan resiko penurunan curah jantung? Yaitu takikardi dengan frekuensi jantung di atas 150. Walaupun kita ketahui takikardi itu yaitu semua gambaran EKG yang frekuensi jantung di atas 100. Tetapi di sini digarisbawahi yang akan kita bahas, yang harus segera kita tata laksana adalah takikardi dengan frekuensi jantung di atas 150 kali per menit. Baik, kita lanjut ke dalam materi selanjutnya. Rekan-rekan semuanya, sedikit pendahuluan untuk mengenal jenis-jenis aritmia, bahwa kita ketahui EKG yang normal itu adalah EKG yang diinisiasi oleh SA nodal, yang dikenal dengan EKG sinus, di mana tandanya gelombang P-nya positif diikuti kompleks QRS dan T. Dan memiliki frekuensi 60-100 kali per menit, itu yang disebut dengan sinus rhythm. Ketika frekuensinya kurang dari 60 kali per menit, bahkan bisa di bawah 50 kali per menit, berarti akan masuk atau disebut dengan sinus bradikardi. Nah, sinus bradikardi yang frekuensi di bawah 50 kali per menit, itulah yang harus kita atasi dengan algoritma bradikardi. Kemudian, bagaimana dengan EKG yang diinisiasi oleh afinodal, yang kita kenal dengan EKG junctional? Nah, ciri khasnya gelombang P-nya terbalik. Bisa di depan kompleks QRS, bisa di belakang kompleks QRS, bisa tidak terlihat. Ketika frekuensi jantungnya 40-60 kali per menit, itu disebut dengan junctional rhythm. Artinya kalau kita di lapangan menemukan pasien dengan gambaran junctional rhythm, kita nggak usah panik. Gunakan saja algoritma bradikardi. Kemudian, bagaimana kalau yang menginisiasi serabut Purkinje? Itu EKG yang berasal dari ventricle, di mana ciri khasnya gelombang P-nya tidak ada, kompleks QRS-nya lebar. Ketika frekuensi jantungnya 20-40 kali per menit, itu disebut dengan idioventricular rhythm. Jadi kalau menemukan pasien di lapangan dengan gambaran EKG idioventricular rhythm, pasiennya masih sadar atau nadi karotisnya masih teraba, rekan-rekan gunakan panduan dengan menggunakan algoritma bradikardi. Kemudian ada juga EKG yang diinisiasi oleh atrial, bisa yang dikenal dengan atrial flutter, di mana memiliki ciri khas gelombang P yang seperti gigi gergaji, atau atrial fibrilasi yang iramanya tidak teratur, dengan frekuensi jantungnya bisa lambat, yang disebut dengan atrial fibrilasi slow respon, berarti kita akan menggunakan algoritma bradikardi, karena kalau atrial fibrilasi slow respon berarti frekuensinya di bawah 60, berpotensi di bawah 50. Nggak usah panik, gunakan algoritma bradikardi. Bagaimana kalau atrial fibrilasi yang rapid, yang frekuensi jantung di atas 100? Kan bisa sampai di atas 150. Nggak usah panik juga, gunakan algoritma takikardi. Begitu juga gambaran EKG yang berasal dari supraventricle yang sering dikenal dengan supraventricle takikardi, di mana gambaran EKG supraventricle takikardi karakteristik yang utama frekuensi jantung di atas 150. Berarti rekan-rekan gunakan saja algoritma takikardi. Nah, berikut rekan-rekan pembahasan terkait aritmia. Saya menyebutnya ini algoritma aritmia dengan metode angka 3. Jadi rekan-rekan dengan menggunakan algoritma ini, rekan-rekan bisa memilah-milah gambaran EKG apa atau aritmia seperti apa yang berpotensi frekuensi jantungnya di bawah 60 dan yang berpotensi frekuensi jantungnya di atas 150. Nah, di sini ada gambaran EKG yang berasal dari SA nodal yang disebut sinus. Oh, tadi berarti sinus bradikardi bisa di bawah 50. Oh, atrial fibrilasi tadi yang slow respon bisa di bawah 50. Yang rapid respon bisa di atas 150, berarti kita gunakan algoritma takikardi. EKG yang berasal dari afinodal, ada junctional rhythm, frekuensi jantung 40-60 kali per menit, kita akan gunakan algoritma bradikardi. Bagaimana kalau yang API block? Nah, API block ini baik API block derajat 2 tipe 2 maupun total API block, ini lebih cenderung frekuensi jantungnya di bawah 50. Berarti kita akan menggunakan algoritma bradikardi. Nah, bagaimana dengan supraventricle takikardi, di mana frekuensi jantungnya di atas 150, kita akan gunakan algoritma takikardi. Dari ventricle, ketika gambaran EKG idioventricular rhythm, kita akan menggunakan algoritma bradikardi, dan ketika gambaran EKG-nya ventricle takikardi, frekuensi jantung berpotensi di atas 150, kita akan gunakan algoritma takikardi. Baik, untuk pendahuluan saya kira cukup. Nanti kalau rekan-rekan ingin lebih paham lagi terkait dengan aritmia, silakan untuk belajar secara mandiri atau ketemu lagi dalam pelatihan interpretasi EKG. Ya. Sekarang kita kupas, kita fokus terkait dengan takiaritmia atau takikardia. Kita paham yang namanya takikardi itu ketika frekuensi jantung di atas 100 kali per menit, dan yang akan menimbulkan gejala yaitu takikardi yang di atas 150. Gejala apa yang sering kita temukan? Yaitu terjadinya penurunan curah jantung karena kebutuhan oksigen miokardium meningkat. Dan ini juga bisa disertai dengan gejala. Contoh gejalanya apa? Pasien akan mengalami perubahan status mental. Yang disebut perubahan status mental itu seperti apa? Contoh pasien mengeluh sakit kepala, mengeluh pusing, sampai pasiennya ada riwayat pingsan atau tidak sadar, atau pasien datang ketemu dengan kita sudah dalam keadaan tidak sadarkan diri. Berarti pasien sudah mengalami perubahan status mental. Yang kedua, disertai keluhan nyeri dada. Jadi hati-hati kalau rekan-rekan menemukan pasien frekuensi jantung di atas 150, timbul nyeri dada, berarti takikardinya itu sudah menimbulkan gejala. Yang ketiga, ditemukan adanya tanda-tanda gagal jantung. Pasien frekuensi jantung di atas 150, pasiennya mengeluh sesak napas, ronhinya positif, suara jantung terdengar suara galop. Oh, berarti udah ada tanda-tanda gagal jantung nih. Berarti itu pun salah satu takikardi yang harus segera kita atasi. Yang keempat, kalau rekan-rekan sudah menemukan tanda penurunan curah jantung, yaitu systolic blood pressure-nya sampai di bawah 90 mm Hg. Berarti kita harus antisipasi nih. Oh, jangan sampai pasiennya henti jantung, cardiac arrest, gitu ya. Kita tata laksana aja dengan algoritma takikardi. Kemudian yang kelima, disertai adanya tanda-tanda shock. Contoh yang paling mudah kita dapatkan di lapangan, pasien akralnya dingin, gitu ya. Itu salah satu tanda bahwa pasiennya mengalami tanda-tanda shock. Baik, kita lanjut. Nah, berarti kalau kita simpulkan kembali, oh takikardi atau takiaritmia itu ada dua jenis. Ada takikardi dengan kompleks QRS sempit, ada takikardi dengan kompleks QRS lebar. Tadi takikardi dengan kompleks QRS sempit itu bisa berasal dari sinus takikardi, bisa atrial flutter, bisa atrial takikardi, bisa junctional takikardi. Bisa juga atrial fibrilasi yang rapid ventricular response untuk yang iramanya tidak teratur, bisa juga multifokal atrial takikardi. Sedangkan takikardi dengan kompleks QRS lebar, ada yang dikenal dengan takikardi atau ventricle takikardi monomorfik. Yang tidak teraturnya ada atrial fibrilasi yang aberrans, dan ada juga ventricle takikardi yang polimorfik. Tentunya kita akan bahas yang mudah-mudah dulu aja ya. Kalau yang kompleks-kompleks nanti belakangan saja. Kita lanjut. Nah, contoh rekan-rekan ketika melihat gambar EKG ini ventricle fibrilasi. Tentunya ventricle fibrilasi sering ditemukan pada pasien dengan cardiac arrest atau henti jantung. Berarti ini jangan menggunakan algoritma bradikardi, jangan menggunakan algoritma takikardi. Ini harus menggunakan algoritma henti jantung atau algoritma cardiac arrest. Nah, sekarang kalau misalkan kita melihat ini EKG-nya sinus nih, tapi frekuensi jantungnya di atas 100. Kalau kita lihat ini frekuensi jantungnya hanya 125. Oh, masih tenang kita. Karena frekuensi jantungnya belum di atas 150. Ini yang dikenal dengan sinus takikardi. Pasien cemas baru datang juga bisa mengalami sinus takikardi. Pasien demam juga bisa mengalami sinus takikardi. Jadi nggak usah terlalu panik dulu untuk sinus takikardi. Selanjutnya ada yang disebut dengan junctional takikardi. Nah, junctional takikardi juga sama, frekuensi jantungnya di atas 100 kali per menit. Tapi tadi gelombang P-nya terbalik di depan QRS. Kalau frekuensi jantungnya masih di bawah 150, masih tenang kita. Oke, kita lanjut. Nah, gambaran seperti apa yang harus kita waspadai? Contoh pada gambaran EKG supraventricular tachycardia, di mana supraventricular tachycardia itu memiliki frekuensi jantung di atas 150 kali per menit. Nah, inilah yang berpotensi pasiennya akan mengalami perubahan cardiac output. Pasiennya akan disertai dengan tanda dan gejala yang kelima tadi. Ya, atau bisa juga tidak disertai tanda gejala. Pokoknya kalau frekuensi jantung di atas 150, rekan-rekan gunakan aja algoritma takikardi. Nah, contoh yang ini karena kompleksitasnya lebar, udah jelas ini yang disebut dengan ventricle tachycardia. Di mana ventricle tachycardia itu bisa dengan nadi, bisa tanpa nadi. Artinya, rekan-rekan tidak bisa mengetahui ini ventricle tachycardia tanpa nadi kalau kita belum ketemu dengan pasiennya. Berarti kita harus ngapain? Harus kita cek dulu nadi karotisnya. Kalau nadi karotisnya teraba disebut ventricle tachycardia dengan nadi, kita akan gunakan algoritma takikardi. Kalau nadi karotisnya tidak teraba, berarti ventricle tachycardia tanpa nadi. Kita akan gunakan algoritma cardiac arrest. Baik, nah sekarang bagaimana panduan dari AHA terkait pasien-pasien yang mengalami takikardi? Di sini sudah dijelaskan ada beberapa kolom ya. Jadi rekan-rekan ikutin aja kolom atau ada algoritma. Berarti algoritma itu ikutin dari kolom yang paling atas ke kolom ke bawah, terus aja ikutin panah-panahnya. Nah, di sini algoritma takikardi ini dipergunakan jika kita menemukan pasien dengan frekuensi jantung di atas atau sama dengan 150 kali per menit. Artinya rekan-rekan, kalau ada pasien dengan frekuensi jantung di atas 150 kali per menit, bisa dua kondisi. Yang pertama, kondisi pasiennya dengan nadi. Yang kedua, kondisi pasiennya tanpa nadi. Kalau dengan nadi, berpotensi pasiennya bisa masih sadar. Berarti kalau pasiennya sadar, kita gunakan pendekatan primary assessment. Tetapi kalau pasiennya tidak sadar, kita gunakan pendekatan BLS assessment. Jadi saya ulangi ya. Jadi kalau pasiennya tidak sadar, pendekatan kita gunakan pendekatan BLS assessment. Tapi kalau pasien kita tidak sadar, gunakan pendekatan primary assessment. Yang disebut BLS assessment itu ngapain? Dari mulai 3A, setelah 3A cek respon, setelah cek respon pasien tidak ada respon, aktifkan sistem kegawatan. Kalau tadi disebut dengan aktifkan code blue. Sambil menunggu bantuan datang, kita cek nadi karotisnya. Kalau nadi karotis tidak terapa, kita segera early CPR, segera melakukan RJP. Itu yang disebut dengan BLS assessment. Kalau primary assessment, apa yang dilakukan? Nah, kita identifikasi dan mencari penyebab. Artinya di primary assessment ini pastikan RW-nya aman. Berarti tahapannya dari A, B, C. Setelah RW-nya aman, pastikan breathing-nya aman. Kalau pasien ada desaturasi atau ada tanda hipoksia, segera berikan terapi oksigen. Baru masuk ke C. Di C apa yang harus rekan-rekan lakukan? Rekan-rekan segera memasang monitor. Tujuannya untuk mengetahui apa sih gambaran EKG-nya, sehingga pasiennya itu mengeluh berdebar-debar. Jadi kalau pasien masih sadar, bisa pasien keluhannya berdebar-debar, bisa pasien mengeluhnya pusing, sakit kepala, bisa pasiennya tidak sadar, bisa pasiennya mengeluh nyeri dada, atau rekan-rekan akan menemukan tanda-tanda yang lainnya. Nah, di sini di C, rekan-rekan dipandu. Identifikasi apa gambaran EKG-nya. Yang memiliki frekuensi jantung di atas 150 itu banyak tadi. Bisa supraventricular tachycardia, bisa ventricle tachycardia, bisa atrial fibrilasi yang rapid ventricular response. Di sini dipandu juga, segera pasang monitor tekanan darah. Monitor blood pressure-nya. Berarti sekarang kita lakukan pengukuran tekanan darah. Hati-hati atau tekanan darahnya kurang dari 90 mmHg. Kemudian segera pasang oksimetri. Nah, sambil memasang oksimetri, sambil dipegang akralnya. Ada nggak tanda-tanda shock? Nah, jadi rekan-rekan tahapannya, kalau pada pasien takikardi, karena pasiennya Kalau masih sadar, gunakan tahapan primary assessment. Kita kupas satu persatu. Nah, jadi tadi manajemen takikardi kita akan gunakan ketika frekuensi jantung di atas 150. Ketika pasiennya tidak sadar, pasien takikardi ini bisa dua pendekatan, bisa menggunakan BLS assessment, bisa primary assessment, bisa secondary assessment. Nah, sekarang bagaimana untuk pasien yang masih sadar, takikardi pasien yang masih sadar atau nadi karotisnya masih teraba? Rekan-rekan tugasnya mengidentifikasi dan mencari penyebab. Jadi rekan-rekan sebagai para perawat jangan langsung panik. Wah, ada pasien mengeluh berdebar-debar, langsung lapor. Ada pasien mengeluh sakit kepala, langsung lapor. Rekan-rekan lakukan dulu nih, identifikasi dan mencari penyebab. Pastikan RW-nya aman. Kita tanya, selamat sore Pak, saya dengan Ismail. Apa yang bisa saya bantu? Aduh Pak Ismail, dada saya berdebar-debar. Oh, berarti masih aman. RW pasien masih aman. Kita lihat pernapasan pasiennya. Kalau pernapasan pasiennya 26 kali per menit, segera kita berikan terapi oksigen. Segera kita berikan posisi semipolar dulu. Dengan posisi pasiennya masih mengeluh sesak napas, kita berikan oksigen binasal dulu. Kalau ada tanda-tanda hipoksia, apalagi segera berikan terapi oksigen sesuai kebutuhan. Setelah A kita lakukan, B kita lakukan, masuk ke C. Apa yang kita lakukan? Kita segera pasang monitor EKG. Ternyata kita temukan frekuensi jantungnya di atas 150 kali per menit. Oh, berarti kita cocok menggunakan algoritma takikardi. Segera ukur tekanan darahnya. Segera pasang oksimetrinya. Kemudian rekan-rekan, di sini ada tindakan mandiri yang bisa rekan-rekan kerjakan sebagai seorang perawat. Apa itu yang harus rekan-rekan lakukan setelah mengkaji airway, breathing, dan sirkulasi? Rekan-rekan kalau sudah menemukan frekuensi jantung pasien di atas 150, segera pasang IV akses. Jadi segera pasang IV akses. Jangan lupa sambil mengambil sampel darah. Buat apa kita ambil sampel darah? Karena tugas kita juga harus mencari penyebab. Kenapa pasien kita ini bisa takikardi? Contohnya, pasien serangan jantung koroner bisa mengalami takikardi. Tentunya kita periksa, ambil sampel darah untuk memeriksa enzim jantung. Yang terakhir, lakukan perekaman EKG jika memungkinkan. Artinya jika memungkinkan itu contohnya bagaimana? Oh, tekanan darahnya masih bagus, oksigennya masih bagus, pasiennya masih sadar, kita masih sempat lakukan dulu perekaman EKG 12 lead. Tetapi kalau kita temukan pasiennya mengeluh sakit kepala, nyeri dada, ada hipotensi, kemudian klinis pasiennya juga gelisah, kita nggak bisa melakukan perekaman EKG 12 lead. Segera kita kolaborasi untuk melakukan tata laksana yang tepat. Nah, selanjutnya apa yang harus kita lakukan? Nah, di kolom yang ketiga, rekan-rekan harus mampu mengidentifikasi apakah takikardi yang dialami oleh pasien kita ini termasuk takikardi yang stabil atau tidak stabil. Bagaimana mengetahui takikardi stabil atau tidak stabil? Ada 5 kriterianya. Yang pertama, kalau di sini ya, ada hipotensi. Ada perubahan status mental yang kedua. Yang ketiga, ada tanda-tanda shock. Yang ketiga, ada keluhan nyeri dada. Yang keempat, ada tanda gagal jantung. Nah, saya suka membuat jembatan keledainya. Agar rekan-rekan mudah memahaminya, ketika kita menemukan pasien frekuensi jantung di atas 150, rekan-rekan kaji dari kepala. Ada nggak perubahan status mental? Kita tanya, Bapak ada keluhan pusing nggak? Ada sakit kepala nggak? Ada riwayat pingsan nggak? Kalau pasiennya sudah pingsan, ya nggak bisa ditanya. Keluarganya yang ditanya, berarti ya. Berarti udah terjadi perubahan status mental kalau pasiennya sudah pingsan. Jadi dari kepala itu untuk mengkaji, ada nggak perubahan status mental? Dari kepala turun ke dada. Adakah keluhan nyeri dada? Kemudian ada nggak tanda gagal jantung? Tanda gagal jantung akut itu yang paling mudah kita identifikasi, frekuensi pernapasannya meningkat. Terdengar suara ronhi. Wah, ini pasien udah ada tanda gagal jantung nih. Kemudian dari dada ke bahu. Ada nggak tanda hipotensi? Nah, kita tadi sambil mengukur tekanan darah, kita harus menganalisa. Ini ada nggak tanda-tanda hipotensi? Atau systolic blood pressure kurang dari 90 mm/Hg. Kemudian sambil kita pasang saturasi, pegang, ada nggak tanda-tanda shock? Jadi begitu triknya ya. Dari kepala, ada nggak perubahan status mental? Turun ke dada, ada nggak nyeri dada? Ada nggak tanda gagal jantung akut? Turun ke bahu, ada nggak tanda hipotensi? Turun ke lengan, ada nggak tanda-tanda shock? Nah, Pak Ismail, kapan dikatakan ini takikardi stabil atau tidak stabil? Jika kita menemukan salah satu dari kelima tanda ini, dikatakan takikardi yang dialami pasien itu yang tidak stabil. Oke, kita lanjut. Jadi kita simpulkan, kalau kita menemukan salah satu dari 5 kriteria ini, berarti kita katakan unstable takikardi atau takikardi yang tidak stabil. Kalau kita tidak menemukan dari kelima kriteria ini tidak muncul satupun, berarti takikardinya takikardi yang stabil. Nah, kita masuk sekarang. Pak Ismail, bagaimana kalau saya menemukan pasien dengan takikardi yang stabil? Nah, pada panduan AHA 2020 ini, di sini diperjelas, kalau kita menemukan takikardi yang tidak stabil, segera siapkan synchronize cardioversi. Kemudian, pertimbangkan untuk pemberian sedasi. Tapi di sini ada poin lagi. Jika teratur, kompleks QRS-nya sempit, irregular narrow kompleks, berarti jika teratur kompleks QRS-nya sempit, gambaran EKG apa ya? Ada yang tahu rekan-rekan? Kira-kira gambaran EKG apa? Jika teratur kompleks QRS-nya sempit, ada yang tahu gambaran EKG apa? Silakan, ada yang mau berespon? Oh, nggak bisa ya? Nggak bisa berespon ya dengan peserta. Oke. Berarti contohnya gambar EKG supraventricular tachycardia. Di sini pertimbangkan pemberian adenosin. Jadi kalau gambaran EKG-nya supraventricular tachycardia, boleh juga tidak langsung synchronize cardioversi. Tetapi kita dengan kolaborasi untuk pemberian adenosin. Artinya apa? Artinya rekan-rekan harus paham bagaimana cara pemberian adenosin. Nah, di sini dipertegas rekan-rekan. Pemberian adenosis ini, dosis yang pertama 6 mg. Ini diberikan dengan cepat. Jadi 6 mg, tapi siapkan pembilas, nanti dibolus, nanti langsung segera dibilas, secepat mungkin, ini 6 mg. Kalau tidak respon, bisa lakukan langsung percobaan yang kedua dengan 12 mg. Jadi pemberian adenosin itu bisa 6 mg, kalau tidak berespon, lanjut dengan 12 mg. Kalau tidak respon lagi, berarti pilihannya ya synchronize cardioversi. Nanti kita akan kupas terkait synchronize cardioversi itu seperti apa sih? Yaitu pemberian elektrikal atau pemberian terapi listrik yang direncanakan dengan modus sinkron. Seperti apa? Nanti mudah-mudahan kita sempat untuk memutar videonya. Baik, nah contoh ini ternyata udah saya siapkan videonya ya. Oke, sebentar, saya harus share sound ya. Biar nanti rekan-rekan bisa dengar suaranya. Rekan-rekan, video kardioversi ini sebenarnya saya sudah share di YouTube. Silakan rekan-rekan kunjungi aja II Ismail Channel. Di situ ada berbagai pembelajaran terkait dengan kardiovaskuler. Nah, contoh kita akan coba melihat seperti apa sih proses kardioversi. Saya percepat ya. Ada pasien dengan supraventricular tachycardia. Oke. Ini ada pasien dengan supraventricular tachycardia di mana pasiennya tidak stabil karena pasiennya ada hipotensi. Kemudian pasiennya sudah dicoba dengan pemberian adenosin, rekan-rekan. Tetapi setelah diberikan adenosin, ternyata tidak berespon juga. Akhirnya pasien ini disiapkan untuk kardioversi. Kita sebagai tim harus menyiapkan. Oh, di sini ada tim yang bertugas untuk di airway breathing management. Ini ada tim yang bertugas di bagian medikasi, menyiapkan obat-obatan. Karena tadi pertimbangkan pemberian sedasi. Nggak mungkin pasiennya sadar, kita berikan terapi listrik. Jadi kita harus berikan dulu biar pasien tidak sadar. Kemudian saya bertugas di bagian electrical terapi. Dan nanti ada dokter jaganya sebagai leadernya. Jadi pada tata laksana takikardi ini ada 4 orang yang terlibat. Siapkan untuk tindakan sinkronis kardioversi. Ini ada Dokter Andika. Nah, ini dokternya. Pak Beni, pada kesempatan pasiennya sudah diedukasi ya. Nah, saya percepat mengisi form edukasi sendiri. Apa yang harus disiapkan? Kita siapkan troli emergency. Kita sudah siapkan dengan modus sinkronis. Lengkap dengan defibrillator. Kita lihat modusnya modus sinkronis bahwa kita sudah siap sinkronis dengan energi 50 joule. Dan pedalnya kita sudah siapkan dengan jelly. Oke, kalau semua sudah siap. Artinya rekan-rekan, kata kuncinya begini. Kalau rekan-rekan di lapangan menemukan pasien frekuensi jantung di atas 150, saya sarankan sebagai seorang perawatnya segera monitoring pasiennya menggunakan monitor defibrillator lengkap dengan troli emergency. Kenapa? Karena kalau disimpulkan nanti pasien ini tidak stabil, berarti pasiennya diperlukan tindakan kardioversi. Tindakan kardioversi memerlukan defibrillator. Nah, itulah peran rekan-rekan nanti ya di lapangan. Baik, kita lanjut. Kita mulai dari pemberian sedasi. Nah, pasien diberikan sedasi. Sedasi sudah diberikan. Saya percepat rekan-rekan. 2. Pasien sudah diberikan sedasi. Nah, pasien ketika tidak sadar dilakukan kardioversi.
Clear.
Oke, setelah kardioversi dilakukan, kita akan patensi jalan napas yang di airway breathing untuk memberikan terapi oksigen.
Sudah, Pak.
Sebenarnya bisa menggunakan non-rebreathing mask ya kalau pasiennya bernapas spontan dan adekuat.
Ya, tinggal dirapikan. Oke, tenang, Pak. Tenang, Pak.
Oke, kita lihat gambaran EKG-nya sekarang.
Gambaran EKG-nya berubah menjadi sinus takikardi.
Jadi tadi yang frekuensi jantungnya 200 kali per menit, sekarang EKG-nya menjadi sinus takikardi dengan frekuensi jantung 128 kali per menit.
Kita akan lanjut untuk stabilisasi pasien post kardioversi. Sampai ketemu lagi.
Oke, seperti itu rekan-rekan tindakan yang disebut dengan synchronized kardioversi. Kita lanjut. Selanjutnya, Pak Ismail, bagaimana kalau pasien yang takikardi dengan frekuensi jantung di atas 150, setelah saya analisa, kelima kriteria itu tidak kita temukan. Lanjut ke kolom berikutnya. Di sini timbul lagi pertanyaan, perhatikan, kompleks QRS-nya lebar atau kompleks QRS-nya sempit. Dikatakan lebar itu jika lebih dari 3 kotak kecil. Dikatakan sempit jika kurang dari 3 kotak kecil. Nah, seperti ini ya. Kemudian kita lanjut, bagaimana kalau kompleks QRS-nya lebar? Kalau kompleks QRS-nya lebar, di sini pilihan yang pertama ternyata pemberian adenosin juga. Jadi pemberian adenosin jika teratur, jadi walaupun kompleks QRS-nya lebar tapi teratur atau monomorfik, atau dikenal dengan gambaran EKG ventricle tachycardia monomorfik, boleh juga diberikan dulu adenosin. Jadi 6 mg tidak respon, baru 12 mg. Kalau tidak respon juga, pilihan yang kedua adalah pemberian obat anti aritmia. Nah, anti aritmia yang direkomendasikan yaitu amiodaron. Amiodaron kita berikan bolus 150 mg selama 10 menit. Jangan lupa diencerkan dengan dextrose 5% menjadi 20 cc atau 50 cc. Nanti bolusnya bolus pelan ya. 10 menit. Boleh nggak menggunakan syring pump? Boleh, silakan. Karena lumayan pegel ya. Kalau memberikan manual 10 menit, bayangkan selama 10 menit kita memberikan obat sedikit-sedikit. Kalau ada syring pump, lebih baik. Lanjutkan maintenance-nya 1 mg per menit selama 6 jam. Nah, ini semua panduannya sudah ada di kolom kotak yang warna hitam ini. Jadi bagaimana cara pemberian amiodaron? Prokainamid saya tidak bahas karena di Indonesia jarang kita menemukan prokainamid yang ada amiodaron. Berarti saya fokus obat-obatan yang ada beredar di kita ya. Jadi pemberian amiodaron itu dosis yang pertama 150, dilanjutkan maintenance-nya itu 360 mg per 6 jam. Rekan-rekan sering memberikan amiodaron ini langsung 360 mg diberikan selama 6 jam. Nah, itu saya tidak rekomendasikan. Kenapa? Karena rekan-rekan akan memberikan bonus ke pasien menjadi plebitis nanti, karena terlalu pekat. Jadi saya rekomendasikan pemberiannya diberikan dalam 3 tahap. Jadi rekan-rekan ambil dulu 150 mg, diencerkan menjadi 50 cc dengan dextrose, berikan dalam waktu 2,5 jam. Setelah selesai, ambil lagi 150 mg, encerkan lagi, diberikan lagi dalam 2,5 jam. Kan darah penanya lagi IP aksesnya 1 jam yang kita kerjakan karena kurang rekomendasikan pemberian amiodaron itu diputra. Jadi untuk bolusnya silakan, tetapi untuk maintenance-nya diusulkan. Baik, kita lanjut. Tes 1 2 3, suara saya terdengar? Ibu Mira, apakah suara saya terdengar dengan baik?
Terdengar, Pak.
Oh, siap. Baik, kita lanjutkan.
Silahkan.
Baik.
Waktunya tinggal sedikit lagi ya Pak ya.
Aduh, mohon maaf. Nah, sekarang bagaimana kalau kompleks QRS-nya sempit? Kalau tadi kan lebar, sekarang bagaimana kalau kompleks QRS-nya sempit? Nah, kompleks QRS sempit ini ada beberapa panduan. Yang pertama, kita boleh kolaborasi untuk melakukan pagal manuver. Ketika kita temukan iramanya teratur, irregular. Berarti contoh gambaran EKG apa? Gambaran EKG supraventricular tachycardia yang boleh dilakukan pagal manuver. Kemudian kompleks QRS sempit juga boleh diberikan adenosin jika regular. Berarti gambaran EKG supraventricular tachycardia. Karena yang kompleks QRS sempit juga bisa atrial fibrilasi tadi. Nah, berarti kalau atrial fibrilasi tidak boleh dilakukan pagal manuver, tidak boleh diberikan adenosin. Nanti kalsium channel blocker aja atau beta blocker yang diberikan. Kalau bingung, nanti konsul ke ahli. Nah, rekan-rekan semuanya, di sini saya akan memberikan contoh terkait pemberian modifikasi falsafah manuver, yaitu tata laksana pagal manuver tanpa pemberian obat-obatan. Jadi dengan cara merubah posisi saja. Literaturnya sudah banyak, nanti silakan rekan-rekan dikupas literaturnya. Saya akan menyingkat videonya. Nah, ini pasien dengan supraventricular tachycardia. Usahakan pasien sudah ada troli emergensi, pasien sudah diberikan oksigen. Oke, Ibu nanti tarik nafas. Ini pasien frekuensi jantung 158, 159. Pasien akan diberikan perubahan posisi. Ada 3 perubahan posisi. Yang pertama, pasien duduk. Nanti kita instruksikan untuk meniup spuit selama 15 detik. Sampai si yang hitamnya itu terdorong ke angka 20. Berarti menggunakan spuit yang 20 cc. Kemudian posisi pasiennya duduk ya. Nanti posisi pasien dibuat terlentang, kakinya dielevasikan 45 derajat dalam waktu 15 detik. Kemudian pasien kembali lagi dalam posisi duduk dalam waktu 30 detik. Kita akan lihat video lengkapnya. Tarik terus tiup sekaligus ya. Ya, tiup. Ya, tarik dulu, tarik. Tiup. 1, 2, 3, 4, 5. Jadi kita pandu. 7, 8, 9, 10, 11, 12, 13, 14, 15. Oke, posisinya dirubah. Maaf ya, Bu ya. Oke, 1, 2, 3, 4, 5, 6, 7, 8,
9, 10, 11, 12, 13, 14, 15, iya. Nah, batukin boleh, batukin.
Nah, kita lihat.
Ya, batukin.
Sekarang frekuensi
Ya,
jantungnya
oke.
mulai melambat.
Oke. Atur napasnya, tarik. Agak pusing dikit ya.
Kembali lagi
Oke.
EKG-nya menjadi EKG sinus.
Oke, sekarang debarannya berkurang nggak?
Tahu dok.
Kalau dilihat dari monitor sih harusnya berkurang.
Di sini kayak ada.
Nggak enak ya? Tapi sekarang udah berkurang ya?
Frekuensi jantung sekarang 110
Oke,
kali per
tenang,
menit.
tenang. Oke, Ibu istirahat lagi, santai.
Ini gambaran EKG sebelum modifikasi falsafah manuver, dan ini gambaran EKG setelah modifikasi falsafah manuver. Baik, kita lanjut. Nah, selanjutnya, Pak Ismail, bagaimana kalau gambaran EKG-nya masih menetap? Kalau pasiennya tadi dengan kardioversi, berarti tetap kita cari penyebabnya. Kenapa pasien ini takikardi? Kalau pasien postkardioversi tadi dengan 50 Joule tidak respon, kita bisa naikkan energinya. Kemudian kalau pasien dikasih obat anti aritmia, tadi baru diberikan bolus, lanjutkan ke dalam maintenance. Kalau masih galau, kita masih ada waktu untuk konsul ke ahli atau ke pakar aritmia. Jadi rekan-rekan ketika menemukan pasien takikardi, nggak usah panik, ikuti aja algoritma takikardi. Baik. Kita lanjut ke bradikardi. Nah, ini untuk kardioversi ya rekan-rekan. Kalau misalkan untuk SPT bisa mulai dari 50 Joule. Kalau untuk QRS yang lebar dan teratur berarti bisa mulai dari 100 Joule. Kalau kompleks QRS-nya sempit tidak teratur, contohnya atrial fibrillasi, kita bisa mulai dari 120 Joule. Sekarang untuk bradikardi. Bradikardi yang harus kita waspadai adalah bradikardi yang kurang dari 50 kali per menit. Ini yang sering disertai dengan gejala. Nah, rekan-rekan semuanya, kita langsung fokus ke dalam algoritmnya. Macam-macam EKG bradikardi, contohnya junctional rhythm, kemudian AP block derajat 2 tipe 2, kemudian total AP block, kemudian idioventricular rhythm, dan akselerasi idioventricular rhythm. Nah, apa yang harus kita lakukan? Rekan-rekan semuanya, kalau kita lihat algoritma ini, algoritma takikardi dan bradikardi itu beti. Apa itu beti? Beda tipis. Kalau kita lihat di kolom yang kedua, identifikasi dan cari penyebab. Ternyata sama dengan takikardi ya. Bedanya bradikardi jika frekuensi jantung di bawah 50. Berarti rekan-rekan kalau pasien bradikardi pasiennya masih sadar, gunakan pendekatan primary assessment. Pastikan airway-nya aman. Evaluasi breathing-nya. Berikan oksigen sesuai kebutuhan. Baru ke C. Di C ngapain? Pasang monitor, identifikasi gambar EKG-nya. Sama. Kemudian pasang monitor tekanan darah. Sama. Pasang oksimetri. Sama. Segera pasang IP akses. Ambil sampel darah. Sama. Lakukan perekaman EKG 12 lead jika memungkinkan. Sama ya. Bedanya ini ada satu poin nih. Pertimbangkan kemungkinan pasien kita ini hipoksia atau keracunan. Artinya, pasien kita yang mengalami bradikardi, penyebab terseringnya adalah hipoksia atau keracunan. Keracunan apa yang dimaksud? Keracunan obat-obat kardiovaskuler. Mungkin kalau rekan-rekan yang sudah bekerja, sering menemukan pasien yang dapat terapi untuk menurunkan frekuensi jantung. Contohnya obat apa? Bisoprolol, digoxin, metoprolol. Kalau rekan-rekan perhatikan obatnya kecil-kecil ya. Pasien hanya diberikan obat 1,5 kali tablet, gitu ya. Nah, bayangkan kalau pasiennya ini salah minum. Harusnya 1,5 kali tablet, dia 3 kali 1 tablet. Datang ke emergensi karena keracunan obat-obat untuk menurunkan frekuensi jantung. Jadi cari penyebabnya. Jadi penyebab tersering itu di sini ada hipoksia, ada keracunan. Contoh hipoksia ini sering menyebabkan bradikardi. Waktu di era pandemik COVID, banyak pasien dengan COVID-19 mengalami desaturasi. Kalau rekan-rekan pernah merawat pasien dengan COVID-19 yang mengalami desaturasi, ketika akan mengalami kegawatan, diawali dengan bradikardia atau bradiaritmia. Gitu, seperti itu. Nah, apa yang harus kita lakukan? Kaji ini bradikardinya stabil atau tidak stabil. Ada berapa kriteria? Sama, ada 5. Dari kepala ada nggak perubahan status mental, ada nggak nyeri dada, ada nggak tanda gagal jantung, ada nggak hipotensi, ada nggak tanda-tanda shock. Kalau tidak ditemukan dari kelima kriteria ini, pasien hanya cukup dimonitoring dan diobservasi. Jadi nggak usah panik, pasiennya hanya monitoring dan observasi. Setelah diobservasi, oh pasiennya stabil kok, tidak ada masalah, bisa dipulangkan. Tetapi kalau muncul salah satu dari kelima kriteria ini, masuk ke kolom yang di bawah. Nah, pertimbangkan untuk pemberian atropin atau sulpas atropin. Di mana pada panduan AHA 2015, sulpas atropinnya 0,5. Tapi pada AHA 2020, sulpas atropinnya 1 mg bolus. Ingat, karena satu ampul 0,25 nih sulpas atropin, satu ampulnya 0,25 mg, berarti kita butuh 4 ampul kalau mau memberikan 1 mg. Dan
Halo,
sulpas
Pak
atropin bisa diberikan 3-5 menit. Ya.
Halo Pak Ii.
Siap.
Waktunya sudah 10 menit.
Oke, siap. Baik.
Oke.
Baik. 2 menit lagi deh ya.
Oke,
Nanti
oke.
kalau sulpas atropin tidak efektif, bisa dilakukan dengan transcutaneous pacing atau pemberian obat inotropik dopamin atau juga epinefrin. Selanjutnya bisa konsul ke dokter spesialis untuk pemasangan pacu jantung sementara yang dikenal dengan istilah TPM. Nah, rekan-rekan semuanya, untuk video bagaimana cara memasang pacu jantung transkutan, silakan rekan-rekan belajar secara mandiri karena waktu kita yang terbatas. Baik, rekan-rekan, terima kasih atas perhatiannya. Mohon maaf karena waktu kita terbatas. Terima kasih kepada para panitia, kemudian kepada para peserta yang luar biasa mengikuti sampai akhir. Terima kasih, saya tutup. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Terakhir saya tutup dengan pantun, Ibu.
Belum, Pak. Masih ada pertanyaan.
Oh iya, silakan
Ini ada
pertanyaan
satu
dulu.
pertanyaan.
Silakan
Oke.
pertanyaan dulu.
Untuk sementara disimpan dulu ya, Pak.
Ya, silakan.
Oke. Bapak, ini ada satu pertanyaan dari RSUD Kabupaten Bekasi.
Ya.
Saya
Tetangga
Kitiah.
kalau dari Bekasi.
Iya, iya.
Iya.
Saya Kitiah dari RSUD Kabupaten Bekasi. Kebetulan saya dinas di ruangan hemodialisa.
Oh,
Saya
siap.
sering menemukan pasien takikardi intra HD dengan nadi di atas 100, tapi masih di bawah 150.
Ya.
Apakah teknik falsafah bisa kita praktekkan pada pasien intra HD untuk membantu menurunkan nadi? Terima
Bagus.
kasih.
Terima kasih pertanyaannya. Pertanyaan seorang klinisi ya.
Ya,
Jadi
betul, Pak.
rekan-rekan semuanya, ketika supraventricular takikardi yang akan dilakukan modifikasi falsafah manuver, satu syaratnya, supraventricular takikardi yang stabil. Kalau tidak stabil, tidak direkomendasikan. Seperti itu. Jadi harus dikaji dulu, ini stabil atau tidak stabil kondisi pasiennya. Nah, pertanyaannya, pasien dengan kondisi pasien di HD, terpasang banyak device, terpasang banyak akses, ya, apakah memungkinkan? Kan tidak memungkinkan. Berarti menurut saya kurang tepat kalau pada pasien dalam intrahemodialisa, kecuali pasiennya mampu mobilisasi, gitu ya, baru silahkan untuk modifikasi falsafah manuver, catatannya SPT-nya yang stabil. Begitu Bu kata kuncinya.
Oke, terima kasih Pak. Ini ada lagi dari Dr. Sutomo.
Oh,
Dr. Sutomo
silakan.
Surabaya mungkin ini ya Pak ya.
Oh ya.
Oke, dari Ibu Dwi Susanti. Please ask for permission if the patient is traumatized, give for high flow oxygen, while in ACS patient it is only given nasal cannula oxygen. Thank you. Itu Pak pertanyaannya. Jadi pasien traumatik diberikan high flow oxygen While in ACS patient, pasiennya mengalami gangguan jantung ACS, hanya diberikan nasal kanul oksigen. Itu menurut Pak II bagaimana itu?
Oke, baik. Jadi rekan-rekan di dalam kardiovaskuler ini direkomendasikan pemberian oksigen nasal kanul itu jika saturasi oksigen di bawah 94. Jadi kalau pasien dengan akut coronary syndrome sebenarnya nggak harus langsung diberikan oksigen ketika saturasi oksigen masih di atas 94. Tidak perlu gitu ya. Justru yang diperlukan apa? Makanya suka diajarkan ada tata laksananya yang disebut dengan ONAMCO. Kalau oksigen tidak perlu berarti anti nyeri, N-nya nitrat, pemberian nitrat. Kemudian habis nitrat apa? Aspirin gitu ya. Seperti itu. Habis aspirin apa? Clopidogrel. Baru morfin seperti itu. Jadi tidak harus selalu diberikan pemberian terapi oksigen. Cuman masalahnya masyarakat Indonesia ini kalau pasien masuk ke emergensi tidak diberikan oksigen, kesannya itu pasien itu diterlantarkan gitu ya. Betul ya Bapak Ibu? Jadi kesan pasien ditelantarkan. Jadi terapi oksigen itu untuk apa? Untuk memberikan kenyamanan, seolah-olah kita hanya memberikan kenyamanan. Jadi saya pun di emergensi begitu. Saturasi oksigen 98, kita berikan aja lah binasal 3 liter, agar pasiennya tenang. Karena kalau pasien tenang, resiko takikardi menurun gitu ya. Nah itu aja yang kita lakukan.
Ketenangan faktornya.
Betul,
ya, Pak, ya?
ketenangan seperti itu. Seperti
Oke,
itu
Pak
Ibu.
II.
Ya.
Mungkin ini satu lagi aja ya Pak ya,
Ya.
boleh?
Ya, silakan Ibu.
Oke. Ini dari Universitas Airlangga Surabaya Hospital,
Wah,
Ibu
Surabaya nih.
Nur. Ini
Kemarin
dua-duanya
saya
Surabaya nih.
baru ngisi juga di Surabaya tuh.
Oke. Ini lanjutannya sepertinya Pak.
Lanjutan.
Mohon dijelaskan mengapa seorang dengan aktivitas olahraga yang sudah terbiasa seperti itu, irama jantungnya menjadi bradikardi.
Oke,
Nah, itu
bagus.
Pak, terima kasih.
Bagus,
Ini pertanyaan
rekan-rekan
terakhir
semuanya.
mungkin Pak.
Luar biasa. Jadi rekan-rekan semuanya, jantung kita ini kumpulan dari otot polos yang bekerja secara otomatis. Ketika kita pasien tersebut atau orang tersebut sering melatih jantung kita ini untuk terus bekerja secara aktif, contohnya seorang atlet gitu ya. Seorang atlet itu artinya kan aktivitasnya itu selalu dipacu dengan frekuensi yang cepat. Jadi ketika dia istirahat, frekuensi dia itu akan lambat. Kalau mereka orang-orang atlet-atlet itu mungkin frekuensi jantung di bawah 50, mereka merasa, oh saya enjoy nih, nggak ada keluhan, nggak ada apa-apa. Tapi bagi kita yang kurang aktivitas, nggak pernah olahraga, ketika frekuensi kita di bawah 50, kita akan timbul gejala. Pusing lah, gitu ya, nyeri dada lah, seperti itu. Jadi memang itu kompensasi dari jantung kita karena jantungnya yang sering dilatih dengan baik. Bahkan rekan-rekan semuanya, kalau jantung yang sering dilatih dengan baik itu memang bisa mengalami pembesaran. Tapi pembesarannya itu pembesaran yang masih normal. Setiap otot itu ketika dilatih pasti akan mengalami pembesaran. Otot lengan, angkat barbel terus, membesar kan? Nah, jantung kita pun bagaimana cara membuat jantung kita ini akan ototnya bekerja dengan baik, elastisitasnya baik, dengan rutin melakukan olahraga. Jadi jantungnya akan menjadi baik. Sehingga bagi dia, frekuensi jantung 40 kali per menit, cardiac output dia udah bagus. Kenapa? Karena fungsi kontraktilitasnya mantap gitu, semburannya mantap. Jadi walaupun dia frekuensinya lambat, udah tercukupi kebutuhan oksigenisasi, baik untuk otot jantung itu sendiri, maupun untuk neuro dan lain sebagainya. Seperti itu. Makanya kalau pasien bradikardi, kita suka tanya, Bapak, apakah Bapak olahragawan? Oh iya, olahragawan. Ketika kita lihat tekanan darahnya bagus, keluhan tidak ada, ya udah Bapak ini mah bagus, normal untuk Bapak. Gambaran EKG Bapak sama dengan gambaran EKG saya kalau saya sedang tidur gitu kan. Seperti itu, Ibu.
Oke. Terima kasih Bapak. Kalau ini yang benar-benar pertanyaan yang terakhir Pak II.
Ya.
Terima kasih atas segala ilmunya yang telah berbagi dengan kami semua. Saya rasa kami mengucapkan terima kasih atas kesediaan Pak II untuk datang di International Webinar kali ini.
Ya. Berarti boleh saya tutup dengan pantun, Ibu?
Yang ini boleh, Pak.
Baik, rekan-rekan semuanya, tadi kalau mau menyimak video-video pembelajaran, silakan rekan-rekan untuk belajar secara mandiri ya, karena waktu kita terbatas. Mau belajar tentang bantuan hidup dasar, perekaman EKG, interpretasi EKG, maupun terkait ACLS, saya sudah share video pembelajarannya. Tujuannya apa? Agar banyak perawat yang menyukai kardiovaskuler tanpa harus mengikuti pelatihan atau seminar gitu ya. Karena misi saya harus menyebarkan kardiovaskuler ini sampai ke pelosok. Jadi makanya saya membuat video pembelajaran ini. Baik, karena tadi diawali dengan pantun, saya akan tutup dengan sebuah pantun. Burung dara, burung cendrawasih, banyak terdapat di Papua. Cukup sekian, terima kasih. Semoga bermanfaat untuk semua. Wassalamualaikum warahmatullahi wabarakatuh.
Oke, terima kasih. Pantunnya sangat cantik. Oke, thank you for all audience. It's the end of the speaker. So thank you for your attention. And I will back this event to MC. Bu Murti Meningsih, waktunya saya kembalikan ke Ibu. Mangga Ibu.
Okay, thank you, Mrs. Musri as a moderator. Thank you to all the speaker to providing you insight and knowledge about update advanced cardiovascular life support in nursing services. And also, thank you very much to the audience for your kind attention to this international nursing webinar for 2 days with number of participants, almost 600 participants. That was held by Madani Heart Training Center and Master of Nursing Program, Jenderal Ahmad Yani University. Hopefully, you will get useful knowledge, especially for nursing services. As a master of ceremony, I apologize if there are things that make you uncomfortable of this 2 days international nursing webinar. For audience, don't forget to fill in the evaluation form in the chat box to get a certificate for this webinar. E-certificate from this webinar will be sent by the committee for 3 until 7 days after the event via email and WhatsApp. Thank you all. Goodbye and see you again in the next nursing webinar. Bye-bye. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih semuanya.
Terima kasih.
Terima kasih semuanya atas kehadirannya.